video conferencing. As part of our hearing, the microphones will be set on mute to eliminate background noise. So members and witnesses, please unmute your microphone each time you wish to speak so that we don't have to go through, can you hear me? I see lips moving, but no sound. Documents for the record will be sent to, or should be sent to Megan Mullen at the email address we've provided to the staff, and all documents will be entered into the record at the conclusion of the hearing. The chair now recognizes herself for 5 minutes for an opening statement. We begin our hearing today on a really very somber note. This week, our country passed the tragic milestone of losing 200,000 of our fellow Americans to COVID. And last Friday, America lost its most consequential jurist of our time, Justice Ruth Bader Ginsburg, to pancreatic cancer. These painful losses are why we're having this hearing today. Millions of Americans are struggling. They're sick, many are hungry, so many are jobless. Yet on November 10th, the Trump administration, along with Republican attorneys general, will argue before the Supreme Court that it should strike down the entirety of the Affordable Care Act. If successful, and they may be, 21 million Americans will lose health care immediately. Protections for the 133 million Americans with pre-existing conditions such as asthma, diabetes, and the lasting health conditions caused by COVID, which has infected 7 million Americans to date, will be gone. Young adults will lose their ability to stay on their parents' health insurance until the age of 26. Approximately 109 Americans will face lifetime limits on their coverage, keeping them from being able to afford care for expensive illnesses like cancer, hemophilia, and mental health conditions. The title of today's hearing calls the Affordable Care Act a lifeline. This is the first recession where Americans who lose their job-based health coverage have the lifeline of affordable coverage because of the ACA. A recent study by the Kaiser Family Foundation found that for the workers who filed unemployment claims during the pandemic, more than 20 million may be eligible for the ACA's Medicaid or marketplace coverage. Some states, including my home state of California, have embraced the Affordable Care Act's lifeline and offered special enrollment periods. As we'll hear from Peter Lee, the CEO of Covered California, the state offered a special enrollment period during the pandemic. Between March 20th and August 31st, nearly 290,000 Californians signed up for coverage through the enrollment period. I'd like to enter into the record the letter I received from ASFE, Council 57, that said, quote, California's decision to have a special enrollment period for the ACA has been a game changer in the lives of those who have lost their health care coverage when they lost their jobs during the pandemic or have been impacted by the wildfires. Sadly, the Trump administration has not offered a special enrollment period, keeping Americans from the ACA's lifeline. The American Medical Association wrote in a friend of the court briefing that striking down the Affordable Care Act, quote, at a time when the system is struggling to respond to a pandemic, would be a self-inflicted wound that could take decades to heal, unquote. I ask my Republican colleagues to avoid these self-inflicted wounds. End your decade-long fight to repeal and weaken the Affordable Care Act. Join us in passing the HEROES Act to shore up Medicaid coverage for nearly 73.5 million Americans across our country and help save the jobs and health coverage of firefighters, of police officers, teachers, hospital workers, and other essential workers across our country. I thank everyone, and we all look forward to welcoming and hearing from our witnesses. The chair now recognizes Dr. Burgess, the ranking member of the Subcommittee on Health, for 5 minutes for his opening statement. And please remember to unmute. Dr. Bridges with us? If not, then I will recognize the ranking member of the full committee, Walden.
Well, thank you very much, Madam Chair. I assume you can hear me now. I'll go ahead and start. I don't know where Dr. Burgess is, but I want to thank you for this hearing. It could give us a great opportunity to hear from the experts, and I will, on how COVID-19's pandemic has affected healthcare coverage in this country. And so we all need to have this discussion. We know Americans were promised when the Affordable Care Act passed that we'd $2,500 reduction in our insurance premiums. And lo and behold, that obviously never happened. In fact, just the opposite. I remember all the stories when the ACA took over about people who were promised they could keep their health plan or their doctor, and neither of those things panned out well either. And meanwhile, we still have a lot of folks who have no access to care, still in the 10 to 20% range in some places. But I think even as troubling, if not more so, is the issues that have arisen around the edges. Chairman Pallone and I have worked together a lot on this issue of surprise medical billing, something President Trump has been out front and leading on for most of the time in office. And we're very close with that should become law, stop this practice of surprise medical billing, where people think that who have played by all the rules think they should be covered, and then, as we heard in our hearings, it turns out they get stuck with a bill for $50,000 because somebody contracted out some facility within a hospital that their insurance said was covered, and they get stuck. I'm really troubled that we have not provided for continuous and robust funding for our community centers. It is a travesty that this Congress has not done that. As you know, Chairman Pallone and I, with our bill on surprise medical billing, could have funded that. And yet, for whatever set of reasons, that hasn't happened either. And so our community health centers are left wondering in the lurch, how long will they have their funding? How can they do their hiring? And they're hanging out there. And so while we're having this hearing today, and certainly it will be informative, I just sort of suspect that it will go down the lines of my friend's opening statement and perhaps trigger into some of the politics of healthcare as we're 45 days out from the election or whatever it is. And so it's unfortunate. We have worked together on a lot of issues, and there's certainly a lot we could do going forward. It's unfortunate that we did not find common ground on the issues related to high cost of prescription drugs. But trading off innovation for cures, especially as we're seeing the fight on COVID, for the illusion that you're going to get cheaper prices, just didn't make sense. And here we are, having worked together on 21st century cures legislation in the past, and investing in our National Institutes of Health at record amounts, looking forward to the various companies that have spent night and day trying to come up with a vaccine as they move through their trials. We've never needed innovation more, not only in the vaccine world, but also in the world of therapies. And finally, I just say we need to work together to modernize the Strategic National Stockpile. There have been a lot of lessons learned at every phase as we've dealt with this unprecedented pandemic. A pandemic that, by the way, has killed millions across the world. Hundreds of thousands, and it's not just in the U.S. And so I think the Operation Warp Speed is something we should be proud of, as the administration has moved at record pace to break down bureaucratic barriers while maintaining safety and efficacy of whatever pharmaceuticals become available, either treatments, which they're working on, therapies, as well as vaccines. These are twin needs the American people and the healthcare of American people. And the administration has moved at record speed through this process to get these cures out to the public. So I would close with this. I know the issue of pre-existing condition is something that is being done against the public. But let's not forget that it was Republicans in 1996, as part of ERISA, put pre-existing condition protection into law. I have multiple times this Congress, from day one, literally said, if we're going to have this litigation in the courts, shouldn't we come together as a Congress and reaffirm the pre-existing protections for American people? And that effort's been shot down every time by my friends on the other side of the aisle. So there's a lot we can find common ground on. Americans expect us to do that. And I hope that after this hearing gets behind us, we could still this fall and get good things done. And I yield back.
State that Part 3 contained legislation breaking down the cost of prescription drugs so that the government directly negotiates, as we do in the PA and TRICARE. And the committee has passed legislation on the national stockpile. The chair now recognizes the chairman of the program, Pallone. There's some terrible background noise.
Ma'am, I'm having trouble to suspend this.
Everyone on mute, but we don't have that. So it's really, thank you. Oh, there it goes again. Frank, I think we're going to have to speak against this background noise.
Well, how is it now? Do you hear me well or not?
I can hear you. Yes.
All right, let me try to.
Still there. Still there.
All right, thank you, Chairwoman Eshoo. The COVID-19 pandemic has caused an unprecedented health and economic crisis. As mentioned, 200,000 Americans have lost their lives. More than 6 million have been infected with the disease. And of course, tens of millions have lost their jobs. And millions of American families are justifiably anxious and concerned about both their health and their financial security. So as you know, the HEROES Act, which the House passed more than 4 months ago, would provide a lot of support and assistance to struggling families by expanding the healthcare safety net, increasing support to states to fund their Medicaid programs, and ensuring access to free treatment for COVID-19. But unfortunately, Senator McConnell and the Trump administration either do not understand the need for the federal government to take bold action, or worse, they prefer to willfully ignore and downplay the seriousness of the challenge before us. So let me be clear, further delay in passing the HEROES Act or coming up with some kind of a consensus bill will cost us countless lives, lasting damage to our economy, and immeasurable financial hardship to millions of American families. And unfortunately, the Trump administration is not interested in working with Congress to address this crisis. I know the president says he wants this or that, he wants a big bill, but hasn't really seriously sat down with the House leadership to come up with something that we can all agree on. Instead, the administration is actually seeking, in my opinion, to do further damage to our healthcare system and to the social safety net that millions of Americans have turned to during the crisis. And that's because the president continues to support this Republican lawsuit that is now before the Supreme Court to strike down the entire Affordable Care Act in the middle of this pandemic. And now the president and Senate Republicans are trying to jam a Supreme Court nominee through the Senate just a month before the presidential election. And I believe a big part of that is an attempt to seal the fate of the ACA and ensure its demise, because the hearing before the Supreme Court begins in November. Now, I want to remind folks that what is at stake here if the Trump administration succeeds and they do strike, and the Supreme Court does strike down the ACA. We'd have 20 million Americans who would lose their health care coverage. Protections for more than 133 million people with pre-existing conditions would be eliminated. And everyone who has been infected with COVID-19 now has a pre-existing condition, and in my opinion, could qualify as a pre-existing condition. Also, tax credits for affordable health coverage would be gone, and young adults would no longer be able to stay on their parents' insurance until they turn 26. And of course, there's a lot much more that would be repealed with the ACA, like the Indian Healthcare Improvement Act, and the list goes on. But it doesn't have to be this way. Instead of attacking the ACA, the Trump administration could use it to help people in time of crisis. According to a Census Bureau survey, over 3 million Americans have lost employer-sponsored coverage between April and July of this year. Yet the administration has refused to establish a broad special enrollment period. to allow uninsured Americans to sign up for coverage through the ACA marketplaces. And the Trump administration also refuses to invest in outreach and enrollment efforts to make Americans aware of their coverage options, and instead has imposed arbitrary barriers seemingly intended to deter enrollment. In contrast, state-based marketplaces that have implemented broad emergency special enrollment periods have reported significant enrollment during the pandemic. People want to sign up. Now, the Trump administration also continues to undermine Medicaid, even though it has been a lifeline for millions during the pandemic. According to one estimate, since February, Medicaid enrollment has increased by 6 million people. It is never a good time to be without health insurance, and is especially dangerous during a pandemic. A study by the University of Michigan found that even before the pandemic, Medicaid expansion has saved the lives of over 19,000 adults between the ages of 55 and 64. Medicaid is helping people keep health care coverage when they need it most. So today's hearing is an opportunity to better understand the ACA's impact on the status of health coverage amidst the COVID-19 and what needs to be done to expand and improve access to quality, affordable health care. And it's also an opportunity to reflect on what's at stake when the Supreme Court hears oral arguments in Texas versus California on November 11th. While the ACA has been a lifeline for millions during the pandemic, its future once again hangs in the balance with the Supreme Court. And I can't imagine, Madam Chair, that the stakes could be higher right now. So I look forward to the discussion. I think this hearing is very timely, and thank you again, Ms. Escher.
The gentleman yields back to Mr. Walden. Do you have a opening statement for Dr. Burgess? And if not, then we'll proceed with introducing the witnesses.
Unless anybody else on our side wants the time. If not, I think we're prepared to go on to the hearing, Madam Chair.
Okay, thank you, Mr. Walden. The gentleman yields back, and the chair will once again remind members that pursuant to committee rules, all members' written opening statements will be made part of the record. I now would like to welcome and introduce our witnesses for today. The first, Dr. Benjamin Summers, is the Huntley Quelch Professor of Health Policy and Economics at Harvard. It's T.H. Chan School of Public Health. Welcome and thank you, Dr. Summer. Mr. Douglas Holtz-Eakin is the president of the American Action Forum. Thank you for once again coming to our committee and being a witness. We appreciate it. You're always welcome. Dr. Aviva Arendine is the Vice President for Health Policy at the Center on Budget and Policy Priorities. Welcome to you and thank you. Mr. Dean Cameron is the Director of the Idaho Department of Insurance. Welcome to you. And on behalf of the subcommittee, we thank you. And last but not least, Mr. Peter Lee, the Executive Director of Covered California. I've said it before, and I would like to say it again, that the Lee family in California are legendary. His grandfather founded the Palo Alto Medical Clinic. Everyone in that generation, from his grandfather and father and uncles and aunt, were all MDs. So Dr. Summers, you're recognized for 5 minutes and you can unmute so we can hear you. Welcome again and thank you.
Chairman Oneshu, Ranking Member Burgess, and other distinguished members, thank you for having me here today to discuss this important topic. I'm a professor at the Harvard School of Public Health, a health economist, and a physician. And I'd like to make 3 main points in my testimony today. The Affordable Care Act produced the largest drop in the uninsured rate in the U.S. since the creation of Medicare and Medicaid more than 50 years ago, with far-ranging benefits to public health. 20 million people gained health insurance, and nearly a decade of research has shown that the law has produced significant benefits to families of improved affordability and financial security, improved access to primary care, prescription medications, and care for chronic conditions, and downstream improvements in health status across a range of conditions, including surgical diseases like appendicitis, heart disease, cancer, kidney disease, and overall survival, The research is now showing that the ACA has literally been a lifesaver. The second point is that even with the Affordable Care Act, there are still nearly 30 million people in the United States without health insurance before the pandemic. And this number has been rising since 2016. This erosion of coverage has happened during a period of low unemployment. And though the ACA has narrowed disparities, coverage rates are still lowest among low-income families and communities of color. The recent growth in the uninsured rate has happened due to a combination of factors where the administration has taken policy steps to actively undercut the law. These policies include shortening open enrollment periods, cutting funding for advertising and outreach, repeated efforts to repeal the law, which surveys showed left up to a quarter of the public confused as to whether the law was still in effect, as well as defunding important aspects of the law, including cost-sharing reductions for low-income families. Finally, the administration has allowed and in some cases encouraged states to implement policies that make it harder for people to enroll and to maintain their health insurance. The reason this latter point matters is because the uninsured is not a stable population where everyone in it has been uninsured for years and years. Many people move in and out of coverage over time. This is often called churning. And this particularly happens when enrollment in public programs and staying in public programs is made difficult. One prominent recent example encouraged by the administration was work requirements in Medicaid. In research that we recently published, we found that work requirements in the state of Arkansas, the first state to implement them, led to 18,000 people being disenrolled from Medicaid, even though our study found that more than 95% of the target population should have been eligible for coverage, but got caught up in red tape and complications with the new policy. Rather than helping people get enrolled, these policies are roadblocks. All told, roughly half of the 30 million uninsured Americans before the pandemic were already eligible for either Medicaid or marketplace subsidies. Doing better outreach, eliminating red tape, and helping people keep their coverage over time are key policies to reduce this number. The third point is that the COVID pandemic threatens to leave millions more without health insurance. But the ACA is a critical safety net for many who are losing their jobs. Prior to the Affordable Care Act, when U.S. workers lost their coverage through work, roughly 1 in 4 no longer had that insurance by the end of the year. But when we went back and analyzed this data after the implementation of the ACA, what we found was that job loss did not lead to a significant risk of becoming uninsured. While people did lose their employer coverage, large increases in Medicaid and marketplace coverage more than offset that loss. And more broadly, our research shows that the Affordable Care Act produced its largest coverage gains among blue-collar workers, those in agriculture, transportation, construction, and service jobs, many of whom are essential workers during the pandemic, but are also at high risk for losing their jobs during the economic downturn. Finally, on a personal note, I'm a primary care doctor, and I work in a community health center in Boston. I was there yesterday afternoon seeing patients. Many of my patients are essential workers, stocking grocery store shelves, cleaning subway stations, delivering packages, cooking at restaurants, and caring for sick patients in nursing homes and hospitals. The community I work in has been hit very hard by COVID. Even in the best of times, the difference between having health insurance and not having it can mean financial security or financial ruin. It can mean life or death. And in a pandemic, health insurance means being confident that you can get seen, get tested, and get treated if you get sick. To conclude, there's a simple question for the members of the committee here today to face. Do we make it easy or hard for people to get coverage and stay enrolled? During a pandemic, as a primary care doctor and as a public health professor, to me, the answer is incredibly clear. We have to be doing everything we can to get people access to health insurance and health care. I appreciate the opportunity to be here today and to participate in this critical conversation.
Thank you very much, Dr. Summers, for your superb testimony. It's a pleasure now to recognize Douglas Holtz-Eakin. You're recognized for your 5 minutes, and please unmute.
Well, thank you. Ranking Member Walden, members of the committee, it's a privilege to be here today, and I'll make 3 brief points in these remarks, and then I look forward to answering your questions. The first is the obvious one, which is that the large-scale job losses in the second quarter of 2020 really raised the specter of sharp increases in the number of uninsured in the United States. We saw 22 million people lose their jobs in March and April, 20 million in April alone, 10 times more than the previous 1-month job loss in U.S. history. And I was among those who was deeply concerned that there would be a sharp decline in employer-sponsored insurance. And as a result, the specter of large increases in the uninsured during the middle of a pandemic. Since then, we've had a number of studies which have tried to get a handle on just what the risks are on this front. The Kaiser Family Foundation estimated about up to 27 million Americans were at risk of losing their insurance, but pointed out that all but a few million of them would have some other option, a spouse's employer-sponsored insurance, Medicaid, Affordable Care Act, things like that. There was some work done by the Urban Institute that said about 10 million people might lose their insurance, but all but 3 million of those would find coverage somewhere else. Similarly, we've seen estimates of about 5.5 million by Families USA and about 6 million from the Economic Policy Institute. So all of these suggest that you could have potentially a 25% increase in the uninsured, and that's a serious concern for this committee. The Census Bureau, as I noted in my written testimony, has undertaken a remarkable effort to keep track of the welfare of American families during the pandemic through a weekly household pulse survey, which they've constructed. This asks a wide range of questions about the economic and personal welfare of the families, and includes questions about health insurance status. Remarkably, if you look at those data, which began on April 23rd and have been collected through August 31st, they show that over that period, there's been a tiny increase in the rate of insurance in the United States. I think a correct reading of those data is that they bounce up and down on a weekly basis, but we've seen no significant change in the number of uninsured, the rate of uninsurance in the United States. That's I think promising news that the large scale losses, which we feared early in the downturn, have not yet come to happen. But I don't think it's really a cause for complacency. We need to keep an eye on the options that people will have if they do lose their employer-sponsored insurance. And certainly among those options, first and foremost, is the marketplaces of the Affordable Care Act, where it seems to me that the major question is the issue of special enrollment periods. If an individual loses their employer-sponsored insurance due to job loss, they are automatically eligible to enroll in the ACA marketplaces. The question is whether we want to have special enrollment periods to actively recruit those who were not insured prior to the pandemic and now want to take up the opportunity to get into the ACA. Similarly, we have options for Medicaid as coverage. In the Great Recession and as a precedent, the Congress undertook to subsidize COBRA coverage. Giving people help in their COBRA makes some good sense from the point of view of keeping them in their current insurance product, keeping them in there as a result of the current care networks and not switching their physicians in the midst of a pandemic. The downside to that is the take-up wasn't particularly good in our last experience with this. And so whether it be an effective outreach or not, I think is an open question. And then as a matter of completeness, the last option on the table would be the short-term limited duration insurance plans, which are a recent innovation. These may not be ideal for long-term insurance coverage, but seem good as a stopgap measure in the midst of the pandemic. So I'm thrilled to have the chance to be here today. I'm pleased that the committee is looking at this issue, and I look forward to answering your questions.
Thank you very much for your testimony and for joining us once again. The gentleman yields back. Now it's a real pleasure to welcome Dr. Aviva Arendine. You're now recognized for 5 minutes, and please unmute. Thank you again.
Thank you, Madam Chair, and members of the committee for inviting me to testify today. I'll talk about the role that Medicaid and the ACA are playing in the crisis, the need for action to further strengthen health coverage programs, and the catastrophic harm that would occur if the Supreme Court struck down the law. Medicaid has long played a key role in protecting coverage during recessions. During the Great Recession, for example, increased Medicaid and CHIP enrollment fully offset the loss of private coverage for children, preventing any increase in the children's uninsured rate. But before the ACA, this safety net had a gaping hole. It left out many of the adults who were most vulnerable to recessions. With Medicaid expansion and the ACA marketplaces now filling that gap, we'd expect coverage programs to be even more responsive to need than in the past. The data suggests that's exactly what's happening. Through July, Medicaid enrollment in states with available data was up about 8%, and expansion enrollment was up about 13%. Extrapolated nationwide, that would mean Medicaid is covering about 6 million people who might otherwise have become uninsured, with about a quarter covered through expansion. Mid-year signups for ACA coverage seem to be up too, especially in those states that created special enrollment opportunities that are easier to access than the standard SEP. Medicaid and the ACA are also aiding the response to the crisis in other ways. In states that expanded Medicaid, the program covers almost 40% of low-income essential workers, such as home health aides and hospital, transit, and grocery store workers. And low-income people in those jobs are about half as likely to be uninsured in expansion compared to non-expansion states. States are also using Medicaid authorities to respond to the pandemic, for instance, by increasing payments to nursing homes and other health providers, expanding access to home and community-based services, and increasing the use of telehealth. Congressional action is needed to make sure that this safety net doesn't fray under strain. The growing need for Medicaid coverage and other demands on the program coincide with a historic state budget crisis. In past budget crises, states restricted Medicaid eligibility, made it harder for eligible people to get and stay covered, eliminated or cut important benefits, cut provider payments, and cut other non-Medicaid health programs, especially behavioral health. Cuts like those would be especially harmful right now. Congress, with bipartisan leadership from this committee, took a crucial first step back in March, temporarily raising the Medicaid match rate and pairing those funds with strong protections for beneficiaries' coverage. But the growing number of states that are making or considering harmful cuts to Medicaid shows that additional federal funding is needed. Congress should also strengthen the health safety net for this and future recessions by filling remaining gaps. That involves both reversing administration policies that have undermined coverage and taking affirmative steps to improve the ACA's premium tax credits to make it easier for eligible people to get and keep their coverage and to add to the incentives for states to expand Medicaid. Unfortunately, as we've already talked about this morning, there's also a very real danger that the ACA could disappear altogether due to the lawsuit. Before the pandemic, Urban Institute researchers estimated that would cause 20 million people to lose coverage, which means that about 1 in every 14 non-elderly people in the country would lose their health insurance, and about 1 in 10 among Black and Hispanic people. And this year or next, those coverage losses would be significantly larger because more Americans are turning to ACA programs due to the crisis, as all of today's witnesses discuss in our written testimony. Striking down the law would also end protections for people with pre-existing conditions, from heart disease to cancer to diabetes, to the millions of Americans who've just acquired a new pre-existing condition, having had COVID-19. And striking down the ACA would weaken health insurance for those still covered, from the tens of millions of people with employer plans, whose plans imposed annual or lifetime limits before the ACA, to Medicare beneficiaries for whom striking down the law could raise prescription drug costs. It's worth noting that the lawsuit would at the same time cut taxes for the highest income 1 in 1,000 Americans by an average of $198,000 per year, which would also reduce the revenue flowing to the Medicare Trust Fund and speed its insolvency. Before I close, I'd like to just address the notion that there's some viable alternative to the ACA or a forthcoming plan that would avoid those harmful consequences. Examining the actual ACA replacement proposals put forward since 2010 show that they mirror rather than avert the harmful consequences of the lawsuit. That includes jeopardizing coverage for people with pre-existing conditions. Thank you, and I look forward to answering your questions.
Thank you, Doctor. It's really a pleasure to have you with us. The chair now recognizes Mr. Dean Cameron. You're recognized for 5 minutes, and please unmute.
Thank you, Madam Chair. It's a pleasure to be with you. And thank you for the opportunity to testify regarding Idaho's experience regarding health insurance, the ACA, and the COVID-19 pandemic. Idaho's perspective and experience may be unique from what you've previously heard. I hope it will be helpful as you consider broad public policies and the implications on unique demographics of each individual state. Idaho prides itself on being creative and collaborative in finding solutions. It's that collaboration and our regulatory approach which led to the creation of our state-based successful exchanges in the nation. It's that collaboration that's provided consumers with up to 5 competing carriers participating in the individual insurance market. And it's that collaboration which proved critical and improved outcomes during this pandemic. At the outset, the pandemic and Idaho's emergency declaration, the Department of Insurance began meeting virtually weekly with our carriers. We began collaborating on finding solutions and to the barriers and dilemmas caused by the pandemic, which included everything from testing to treatment, to telemedicine, to provider support, to enrollment, to pharmaceutical guidelines. The results are rather remarkable. Without mandating, without requiring, without threatening, all 5 carriers waived copayments, deductibles, and coinsurance on testing and physician visits associated. All 5 carriers waived copayments and deductibles and coinsurance on treatment related to COVID-19. All 5 carriers expanded their telehealth network dramatically, allowing easier access for telehealth visits, allowing nearly every provider to see their patients remotely, and paying those providers as if the patient were being seen in person. Our telehealth usage increased by 120-fold from February to April, and 250-fold from April 2019 to April 2020. We went from 233 telehealth visits in February to 28,503 telehealth visits in the month of April alone. This was especially helpful to our citizens who needed their mental health provider, where we went from 97 visits in February to 11,333. We allowed for early refill of prescriptions and the ability to obtain a 90-day supply without signature logs or in-person visits. We waived eligibility requirements, allowing employees to maintain their coverage while working fewer hours, allowing coverage to be more quickly obtained upon return to work, or allowing furloughed employees to even stay on their group plan. We extended grace periods and reinstatement periods. All 5 of our carriers did this. All 5 of our carriers also provided millions of dollars in timely assistance to providers and consumers of the COVID-19 as non-COVID-19 claims decreased. And I won't take the time in the interest of time to go into all of those. Several of our carriers recently provided millions of dollars in refunds and credits to consumers, some as much as 50% in 1 month. The carriers also contributed greatly to our community efforts, participating in governor's task forces and etc. From my perspective, the carriers have collaborated really well and have really stepped up at a time when all of their employees were working remotely. There was a huge uncertainty also of the impacts of COVID-19. Since then, carriers have filed their individual market premium rate increases, and I'm proud to report that the net increases is 1%. 3 of our carriers actually requested a rate reduction, and 2 of our least expensive carriers had a slight increase. Lastly, just a note on Medicaid. We have seen a dramatic uptick in the number of folks applying for Medicaid during the pandemic, and a number who qualified for Medicaid expansion. That continues to grow. Even with the expanded FMAP match, those numbers are concerning to our state budget at this time, where our economy is good but precarious. Madam Chairman, in these collaboration efforts didn't happen by accident. They required communication, understanding, commitment to our state and our citizens, and I'm honored to be part of that process. And thank you for allowing me to tell part of the story.
Well, thank you very much for telling your story. It's a good story, and we thank you for being with us. Last, but certainly not least, Peter Lee. It's wonderful to see you again. Thank you for always accepting our invitation to testify at our subcommittee. You're recognized for 5 minutes, and please unmute. We don't want to miss a word.
Good morning, Chairwoman Eshoo, and thank you for remarks. I would hope that my uncle Phil Lee is watching you as we speak today. Also, thank you, Ranking Member Walden, distinguished members of the committee. I'm Peter Lee. I'm the Executive Director of Covered California, which is one of the nation's 13 state-based marketplaces. My remarks, written testimony, and just released report from Covered California reflect our experience working for almost 10 years to effectively implement the Affordable Care Act and more recently respond to the COVID-19 pandemic. The pandemic and the resulting economic recession have demonstrated that if implemented well, the ACA is working as it was intended to do. California, like most states across the nation, red and blue, through the Affordable Care Act, have expanded Medicaid, providing coverage to millions. Here in California, immediately after Governor Newsom declared a state of emergency, Covered California opened a COVID-19 special enrollment period and spent millions of dollars to make sure Californians who lost their jobs knew they could come to us. Results? Yeah. We enrolled over twice as many people than the same period the year prior, with almost 290,000 Californians gaining coverage through our COVID-19 special enrollment period. In stark contrast, we project that nearly 500,000 more Americans could have insurance coverage had the 38 states served by the federally facilitated exchange created a COVID special enrollment period and aggressively marketed to Americans to know they had options. These results are not accidental. They could have been predicted. Federal inaction left as many as 500,000 Americans without coverage during a pandemic. This failure to act is one of life and death. Early diagnosis and treatment are critical to getting good care in COVID-19 times. But the pandemic has also put a spotlight on the gaps and shortcomings of the ACA. The pandemic exposed the fragility of employer-sponsored insurance for many Americans and the weaknesses of high-deductible, lower premium plans that many low-income people select in marketplaces. Now, we've seen, and we just heard from the gentleman from Idaho, that many states, federal government, and insurance companies have addressed the realities of COVID-19 by having no cost sharing for consumers for testing and treatment. It is clear that in a pandemic, the public benefits by having potentially infectious individuals get tested and treated. It is less clear why the same logic does not apply to those infectious with other conditions, such as hepatitis, malaria, HIV/AIDS, or tuberculosis. These are common diseases that are not only extremely deadly and costly to our health system, but that disproportionately impact lower income consumers, communities of color, and those who are underinsured in their employer-sponsored insurance markets. During a pandemic, when coverage is of paramount importance, we saw millions suddenly without coverage because they lost their job. We saw millions more discover the inadequacies of their coverage. And perhaps most problematic, we saw many people actually drop coverage altogether. This is precisely the opposite of what should happen during a global pandemic and economic recession. It is in the public interest to have everyone have coverage so they can get help to stay healthy and get needed care, regardless of their health condition. There are ways to strengthen and improve the ACA to make health coverage more affordable and accessible to all Americans. These are going into in more depth in my written testimony, but I'd like to highlight 5 of them. First, you can do what states do, step up, do more outreach. But I need to note, states cannot take the role of federal action. California has taken bold steps to expand subsidies. They can't keep doing that. It requires federal action. Federally, we should increase subsidies for low and middle income consumers, such as using gold plans as a benchmark and limiting premium costs to no more than 8% of income for all, getting rid of the cliff that is hurting middle income consumers. We should provide options for Americans who aren't happy with and have employer coverage that is inadequate. We need to address underlying healthcare costs, such as high prescription drug costs. And finally, we need to, as a nation, directly address healthcare disparities and inequities. The disproportionate impact of COVID-19 on Blacks, Latinos, Asian Pacific Islanders isn't an exception. Sadly, it's the rule that we should be addressing. The ACA is the right law to build upon, and we risk catastrophe if we turn our backs and abandon millions of people it protects. I look forward to responding to the committee's question. Thank you very much for holding this hearing today, Chairwoman Eshoo.
Thank you very much, Mr. Lee. You're always welcome at our committee, and to all of the witnesses, thank you for your testimony. We'll now move to member questions, and the chair will recognize herself for 5 minutes of questions. I have a few rapid fire questions to each witness to establish a baseline of facts, so please answer yes or no. Dr. Summers said in his written testimony that, quote, the ACA provides a highly effective safety net for workers who lose their jobs, unquote. Mr. Holtz-Eakin said in his written testimony that the ACA, quote, appears to be meeting the need, unquote, during the pandemic and recession. Dr. Arendine, Mr. Lee, and Mr. Cameron, yes or no, do you agree with your fellow panelists that the Affordable Care Act is a critical part of our social safety net?
Absolutely.
Dr. Dine, Mr.
Yes.
Lee, Mr. Cameron, all yeses. President Trump was interviewed on July 19th on Fox News and promised, quote, a full and complete healthcare plan within 2 weeks. Yes or no? Are any of you aware of the details of any comprehensive care plan, healthcare plan from the Trump administration? Dr. Summers?
No, I'm not.
Mr. Holtz-Eakin?
No.
Dr. Arendine?
No, except for the repeal policies they've put forward in prior budgets and proposals.
Yeah, well, that's a wrecking ball. Mr. Cameron?
I can't say that I am.
Mr. Lee?
Nope.
Last week, President Trump said during an ABC News town hall, quote, we're going to be doing a healthcare plan very strongly and protect people with pre-existing conditions. Yes or no? Are you aware of the details of any Trump administration policy that protects people with pre-existing conditions? Dr. Summers?
No.
Dr. Holtz-Eakin? Mr. Holtz-Eakin?
No.
Dr. Arendine?
No.
Mr. Cameron?
Many state laws already protect pre-existing conditions, including Idaho's was well in front of the ACA.
But are you aware of any details of the Trump administration policy to protect people with pre-existing conditions? Yes or no?
Madam Chairman, I've heard the Trump administration and others speak of their intent to protect pre-existing conditions, and we stand with that as well.
I don't know what you're standing with. Are you aware of the details? That's what I'm asking. Yes or no?
Madam Chairman, have I seen an actual bill? No, I have not seen a bill.
Okay.
Have I heard them speak?
Mr. Lee?
No, I'm not, but I'd also, Madam Chair, welcome the chance to expand on that.
All right, well, let's see how much time I have left. Yesterday, Politico reported that President Trump is planning to sign an executive order on healthcare coverage later this week. Dr. Arendine, you served as senior counselor at HHS and acting deputy director of OMB. In your experience, how long does it take for the policy ideas espoused in an executive order to go through rulemaking so it can be implemented?
New rulemaking is typically a lengthy process, and that's true even when the objectives and legal authorities are clear.
And when you say they're extended or it takes a long period of time, give us an approximation of that.
A rapid rulemaking process that was really starting from scratch could still be a year-long process.
Wow. On April 3rd, I led a letter with every Democratic member of the Energy and Commerce Committee to CMS Administrator Seema Verma, asking her to allow Americans to enroll in coverage through healthcare.gov during a special enrollment period. 6 months later, there's still no response. No response. Mr. Lee, California provided a special enrollment period. You spoke to it in your both oral and written testimony. That enrollment period was March 20th in response to the COVID pandemic. What was the outcome of it?
Yeah, the results of that special enrollment period were a doubling of enrollment compared to the prior year, meaning we enrolled during that period almost 300,000 Californians, which means about 150,000 more than would have but for that effort. And I do want to underscore, it's not just a special period, because many of those people would be eligible in a normal period. It's marketing, it's outreach, it's letting people know that our doors were wide open. Those were the factors that helped make sure we got so many Californians in the door.
Thank you. I think that my time has expired, and I see that Dr. Burgess, am I right? Dr. Burgess has joined us. So I'll call on Mr. Burgess, and then when the time is appropriate, so that you can be recognized. Do I recognize him now? Well, I'll recognize Dr. Burgess now for his 5 minute of questions. We missed you in the beginning, but we're glad to see that you've joined us. You can unmute. Where are you? I guess he's still not here, so I'll recognize Mr. Walden, the ranking member of the full committee, for 5 minutes of questions.
Thank you, my friend. Thank you, Madam Chair. And thanks to all our witnesses in your testimony as we work together on these issues to make sure people have adequate access to affordable health care. And again, I would repeat that I think we still have a lot of work to do, especially in the areas of price billing. And it's unfortunate that this has not gotten across the finish line yet. And hopefully we can get there so that people who are covered and play by all the rules don't end up getting a bill that they should never get. I mean, there's a big ripoff going on out there, and we need to address it thoughtfully. And I think we have bipartisan legislation will do that. I'd like to go to Mr. Cameron in Idaho. Do you all take advantage of the Children's Health Insurance Program?
Yes, we do, sir.
And what percent of that program is funded by the federal government in Idaho? I know in Oregon it's about 99%.
Yeah, I believe it's close to 80% in Idaho.
How many, do you know off the top of your head how many kids and mothers are signed up on CHIP in Idaho?
You know, I had that data and I don't have it at my fingertips, so I can get it for you, Congressman.
Yeah. As your neighbor just to the west, because I represent all of Eastern Oregon, obviously we pay close attention on that side of the state to what you all are doing. And it's been interesting, states or laboratories. I'd like you to go through again in terms of the using sort of a free enterprise model, it sounds like, in Idaho, the effects you've gotten by competition in your insurance market.
Thank you, Congressman. And I did find the number for you on CHIP. We're at 25,846 in 2019. And
What is that, 25,000?
25,000.
Yeah, I think in Oregon, we're over 122,000 kids. And under Republican leadership, we passed a 10-year fully funded extension of CHIP. When I chaired the committee, that's double the length of any extension the Children's Health Insurance Program for. And I think on the issue of pre-existing condition, it was Republicans in 1996 who led the effort under ERISA. And it's my understanding, as you pointed out, your state has pre-existing protections in place, irrespective of what the Supreme Court may do. I put forward legislation and multiple initiatives on the floor of the House this Congress to double down on that so that we can protect people regardless of what the Supreme Court decision is. People with pre-existing conditions will be protected. But I want to get back to the marketplace in Idaho, what you've seen, what's working.
So our experience is contrary to what some others testified earlier. Our uninsured population actually went up with the passage of the ACA. And it dramatically went up and then started to wane. And then as we got into the 2013 and 14 year, we started seeing significant numbers of individuals leave the marketplace. They were being forced out of coverage. We believe that's because prices were too high. And they could not qualify for subsidies. We are a rural state, and many of our folks could not qualify for the subsidies. It's not just because they were eligible for Medicaid expansion, but it was because they're farmers and their incomes are unpredictable. or their spouses to school teachers, and they couldn't qualify for subsidy. So we've seen a dramatic exodus from our individual market. We've attempted to try and bring those individuals back, bring back the young and the healthy. Many of the provisions of the ACA, in fact, push the young and the healthy away, which drives prices up, which causes more people to leave. And it's a little ironic because some of the numbers that are counted on the uninsured population also include faith-based programs, which a large number of our citizenry has gone to, or short-term plans. We've created a new plan called an enhanced short-term plan that's more like an ACA plan and is tied to the same risk pool. We're trying to address those issues.
And what kind of premiums do you have to charge for that enhanced short-term duration plan?
So our premiums are about 50% lower than the ACA plan. But I want to emphasize we aren't pulling people away from the ACA into those programs. They're part of the same risk pool. So when the carrier filed their rate increases with us this year, that was a net 1%, some of them a decrease. That included those numbers from their enhanced short-term plans as well. We have two carriers offering those plans. There's not been as great an uptick as we had hoped because of the pandemic, I believe, but I think it's a solution that's worth exploring.
All right. Well, I thank you for your participation to all our witnesses today. My time's expired and I yield back, Madam Chair.
The gentleman yields back. It's a pleasure to recognize the chairman of the full committee, Mr. Pallone, for his 5 minutes of questions.
Thank you, Chairwoman Eshoo. I wanted to ask Dr. Aaron Dine about the ACA and the Supreme Court. You know, I know that the ACA has been a lifeline for millions during the pandemic, but its future hangs in the balance because of this Republican effort to repeal it, which is now before the Supreme Court, hearing oral arguments November 11th. And of course, I believe that's the reason why, or a major reason why, the president and McConnell are trying to push a new nominee to vote against to vote in favor of the ACA repeal. So Dr. Aaron Dine, if the Supreme Court agrees with the Republican position that the ACA should be struck down in its entirety, how many individuals would lose coverage?
Pre-pandemic estimates were that 20 million people would lose coverage, and that number would be larger today because millions of people are turning to Medicaid expansion or the marketplaces for coverage during the recession.
And then, Doctor, based on what you know about health insurance prior to the ACA, would people with pre-existing conditions still be able to get affordable health coverage in the event of the Supreme Court repeal?
Prior to the ACA, the individual market really didn't work for people with pre-existing conditions or other serious health needs. They could be denied coverage, they could be charged higher premiums, plans could have major benefit gaps or annual and lifetime limits. And I do just want to address this point that states could somehow protect their markets against those effects. When states, to the extent states try to do that, they face a few big barriers. First, they don't have jurisdiction to reimpose protections in the self-insured large group market. Also, they generally don't have the money, so they're not going to be able to replace the tax credits that actually make a market that helps people that works for people with pre-existing conditions work for all. A state can't do that by itself without the federal funding that would be eliminated.
Thank you. Now, according to the Mayo Clinic, COVID-19 can damage the lung, brain, and heart and possibly have long-term health consequences. Given that, again, if the Supreme Court throws out the ACA, is it likely that having COVID-19 would be considered a pre-existing condition?
My expectation is yes. And I think this goes to a larger problem with insurance markets that don't have any coverage standards, which is that there's a really strong economic logic behind a race to the bottom. So if you're an insurer who doesn't treat COVID as an excludable pre-existing condition, you'd worry all your competitors are doing that, and you're going to attract all those people and have to pay their costs. So you end up excluding it too. And that same logic applies wherever you don't have benefit standards. So whether it's excluding maternity or excluding high-cost drugs, and on, you get this race to the bottom that leaves people without an option for comprehensive coverage.
Well, thank you. Once again, I'm very concerned that the Supreme Court holds the future of healthcare for millions of Americans in its hands, and the Republicans and the president's effort to jam through a justice, that would vote against the ACA jeopardizes its future even further. Let me go to Dr. Summers. I have a little over a minute. Could you just tell me, I know a lot of people have lost their job-based coverage during the pandemic. Where, you can comment on that or tell us, where are people turning for healthcare coverage during this time? And if individuals are still uninsured, what's the reason?
Well, one place that people turn is if they are fortunate enough to have another family member with employer coverage, and that does explain part of why many people losing coverage haven't become uninsured. For those without that good fortune, their situation is either that they're going to rely on Medicaid, which of course depends on the state you live in and the eligibility criteria, and we know that that 12 states have not yet expanded Medicaid. And then we also have the subsidized coverage in the marketplaces where you don't have to be qualifying based on full-time benefit eligible employment. If you have part-time work, if your hours have gotten cut and you have lower income, you still might qualify, and that can be an important source of coverage for people during the pandemic.
But, my concern is, and I think it's indefensible, that the Trump administration has refused to establish a broad open enrollment period or invest in outreach and enrollment efforts during this pandemic, because people don't necessarily know where to turn to. And it's sometimes difficult to enroll, even when you've lost your job. I don't know if you want to comment on that as well.
Yeah, that's absolutely critical. We know that just making people eligible isn't enough to get them covered. Surveys show that people are often confused about how to navigate the process. So aggressive outreach, funding, and support for community efforts to assist people enrolling is critical and is something that both states and the federal government should be doing during the pandemic.
Oh, thank you, Dr. Summers. And turn it back to you, Chairwoman Issue.
The gentleman yields back. Has Dr. Burgess joined us? Are you there, Dr. Burgess? I don't see you. Not seeing Dr. Burgess or hearing his voice. The gentleman from Illinois, Mr. Shimkus, is recognized for his 5 minutes of questions.
Thank you, Madam Chairman, and it's great to be with you, and it's great hearing. I want to first make a statement on just vaccine development. I know it's not the focus of this hearing, but I want to stress that while we're all focused on the work being done by Operation Warp Speed and expediting the development of select vaccine candidates, we still need to embrace the all the above strategy and continue to welcome the contributions of non-Operation Warp Speed companies and products. Operation Warp Speed investment should be purely additive and shouldn't displace other promising solutions that could prove to be superior to what we thought was possible just 6 months ago. And I thank you for that. To the panelists, a real quick, easy question, should be an easy question. And I think it should be an easy yes or no. Is the Constitution of the United States the supreme law of the land? Dr. Summer.
I'm not a lawyer, but I believe yes.
Dr. Holteken.
Yes.
Dr. Aaron Dine.
Also not a lawyer, but yes.
You don't have to be. You could have taken civics, as I used to teach it. So, Mr. Cameron.
Absolutely.
And Mr. Lee.
Yep.
So let's talk about this court case that's coming up. The question to the court is whether this national government can force an individual to buy a product of service from a private company. When this case was litigated before the Supreme Court, the only thing that allowed it to stand was the right to tax, which was not what was discussed when we had our hearings and we even had this debate on the floor. In fact, Republicans continuously said, you are standing on the principle that the federal government has the right to tax. But my colleagues on the left kept saying, no, we can force individual citizens to buy a product or service. And that's how the debate rolled out. Well, under H.R. 1, that tax was removed. The simple solution for Democrats is to reimpose the tax. And that would reestablish the Affordable Care Act. That's the solution, but they're unwilling to do that. So I just want to pose that premise that to me, the Constitution is the preeminent law in the land, and regardless of the good intentions of federal legislation, that is the primary arbiter. And since I support jurists who are strict construction or originalists, that they don't interpret based upon their experiences how the founders would have written the Constitution, that regardless of what should happen, the Supreme Court's rule is to say, is this law constitutional or is it not? And that is the debate before, not whether we liked it or we don't like it, is whether, did the federal government have the right to pass this law on the citizens of the United States? I believe it was an unconstitutional law because of forcing people to buy something that they should not be forced to buy if they don't want it, regardless of the good intentions. Now, in my final time, I can't see the clock, Madam Chairwoman, so if I need to be gavelled down, just go ahead and do that. But in my district, like in Idaho, I hear the ACA is too expensive and it doesn't cover folks who need it. And we've seen what's happened. The co-op proposed there's only 3 of the 26 that are left. Short-term plans are maligned and associates health plans are sabotaged. So if we can go to Dr. Holtz-Eakin and my colleague, a friend from Idaho, if they could talk about this premise, I would appreciate it.
Well, I think from the beginning of the debate over the ACA, one of my concerns has been that it was coverage heavy and delivery system reform light, and as a result wasn't addressing the underlying cost of healthcare, and so insurance costs would inevitably go up. It ran into problems on top of that in terms of pricing, poor competition, often very thin at times. Some states threatened to have parts where only a single provider was there to offer insurance, and so for 10 years we've seen this continual issue of the cost of the health insurance under the ACA.
Mr. Cameron?
Yeah, I would add too, we continue to see cost increases, although the last couple of years have not been as bad. And as those cost increases occur, and many of them occur because they're healthy. I've got like the couple from Twin Falls, Idaho, 62 and 63 years of age, who can't afford $1,500 a month in coverage. They don't qualify for a subsidy, and so they end up opting out. And those are the individuals we need to be back in the pool, in the system, in order to make the ACA or any plan affordable.
Thank you very much, Madam Chairman. I yield back my time.
The gentleman yields back. It's a pleasure to recognize the gentleman from North Carolina, Mr. Butterfield.
Thank you very much, Madam Chair, for convening this hearing today, and thank you for keeping our subcommittee engaged, even though we're facing some unprecedented challenges. And thank you to all of our witnesses. Your testimony today is very valuable. Before I get into my questions, I just want to respond briefly to my friend from Illinois, Mr. Shimkus. The Supreme Court is indeed the law of the land. I served as a judge for 15 years, and certainly I recognize that, and even several years on my state Supreme Court. But sometimes the court is wrong. I refer you to the Dred Scott case of 1857, not to mention the fact that the public loses confidence in the judiciary when it is politicized. I'm just saying. But let me just address my question to Ms. Arendine, Dr. Arendine. We know from experience that when the economy goes south and people lose their jobs, their income goes down. They turn to Medicaid for health insurance, and enrollment in Medicaid increases. And so Medicaid, like SNAP and unemployment insurance, is a counter-cyclical program, meaning that when the economy goes down, enrollment in these programs actually go up. This isn't a bad thing. Medicaid is designed to be there for people when they actually need it. So, Doctor, economic downturns can strain state Medicaid budgets in 2 ways: increase enrollment and decrease state revenues. Can you briefly describe for me how that works and what it means for state budgets?
That's exactly right. During a recession, states see large drops in their revenues, and then they also experience those smaller budget strain from more people signing up for Medicaid and other programs. In this recession, states are also seeing additional strain from specific COVID-19 related costs that they're incurring to try to address the pandemic.
Now, in years past, during economic downturns, Congress has stepped in and provided additional financial help in the form of increased federal funds known as FMAP. Is that correct?
Correct.
And let me ask you this, the Families First Coronavirus Response Act included in my bill that increased FMAP by 6.2 percentage points for the duration of the public health emergency. How does that compare, if you know, to the FMAP increase that Congress included in the Recovery Act during the Great Recession?
So the Recovery Act increase went up and down based on state economic conditions, but at its peak, it was about twice the size of the assistance that was provided in this recession.
I represent the state of North Carolina. In my state, which unfortunately has not expanded Medicaid, over 2 million people, including many children and seniors, receive necessary care from Medicaid. If our states are forced to make budget cuts, what coverage would be at risk?
Based on what we've seen in past recessions, I'd be particularly worried about two things. One is states cutting back on optional services, which are in fact quite critical, like home and community-based services for seniors and people with disabilities, as well as dental and vision coverage. I'd also be very concerned about states seeking to introduce procedural hurdles that make it harder to get covered, and so cutting costs by reducing the number of eligible people who are actually able to get access to the program. That includes children as well as others.
Would reimbursement rates be affected, in your opinion, to the providers?
Absolutely, and that's something we're already seeing, even with the Families First FMAP and the protections that came with it, is that a number of states are cutting provider rates, including for some providers that are particularly financially fragile right now.
Well, the Senate hasn't passed the HEROES Act, and you certainly know that the HEROES Act contained a 14-point FMAP increase, and I'm just so disappointed that our Senate Republican colleagues have just been unwilling to move that legislation. Madam Chairman, I think I'm going to stop there and yield back. Thank you.
The gentleman yields back. It's a pleasure to recognize now the gentleman from Kentucky, Mr. Guthrie, for his 5 minutes of questions, and please unmute.
Thank you, Madam Chair. I believe that I have unmuted. Thank you very much. Dr. Hozikin, you talked about this, I think, as your second point, if I remember your 3 points. And like Idaho, I have a district that has a lot of small businesses, farmers, people that are typically in the individual market, quite a bit of people in the individual market, and have seen a large increase in premiums. And so that's what we have to balance. How do we get coverage? How do we get items covered? And how do we decrease premiums? And one of the ways the architects of the Affordable Care Act tried, one was individual mandate, but the other one is enrollment periods. And so now we're talking about, talking about a special enrollment period has been proposed. In my understanding, if you're working for, if I'm correct, if you have a job, an employer, and you have employer-sponsored health insurance, and you lose your job, therefore your health insurance due to the crisis, then you can enroll in another program. I know we may have to do assistance. I understand that that's expensive, and we may have to look at that. But you already have the right to enroll in another program if you lose your employer-sponsored health insurance under the current law, correct?
That's correct.
So we have a special enrollment period. A special enrollment period would benefit those who made a choice not to purchase health insurance, either through their employer or individual market, therefore made the choice not to pay premiums. But now that we have a pandemic and we open up the enrollment period, they can go into the marketplace even though they haven't paid premiums. So what would that do to the cost of health insurance for everybody else if people made a choice not to buy health insurance and now can buy it because there's a pandemic moving forward and they haven't been paying premiums the whole time?
Certainly, you run the risk of getting some very expensive people into the pool who are not priced by the insurers at the beginning of the plan year and running into financial difficulties for those insurers. That's not a hypothetical. We saw this repeatedly during the startup of the ACA when there were about 13 special provisions under which you could enter the marketplaces during the middle of the plan year. And the insurers repeatedly complained about how it made it impossible for them to manage their offerings effectively, how they, as a result, had to price in increases to anticipate people jumping in. And often those individuals would then jump back out and get a chance to re-enroll somewhere else on the next year.
That's my point. It's not what it does to insurers. But what insurers
That's
do to
prices.
make up for that? What happened? What's the end result?
Premiums went up. They had to raise premiums to anticipate this phenomenon.
So those in the marketplace pay more.
Yeah.
If you have a special role. That's the concern I wanted to bring up. So the second thing on this economic, and as we've seen from Idaho and experience that I have, is that causes more people to file out of health insurance. I know the person that I took my car and they got a transmission fixed, and the guy said, well, I'm only here certain hours because in the morning and afternoon, I drive a school bus because I'm driving because essentially I'm driving a school bus for $1,600 a month, because that's what he's an individual small business, sole proprietor, transmission business. But in this economic downturn, we have had big effects. And so I want to talk about health insurance coverage and effects from this. How does this downturn differ from other, like the post-financial crisis downturn? Are some of the job numbers that we've seen in recent weeks indicative of any of those differences? And as the economy starts to come back, does that affect what policies you recommend to address any remaining coverage issues?
This downturn is unlike any previous downturn in the United States. It is characterized by a sharp decline in household spending, particularly spending by affluent households on those services which involve personal contact. And that began in mid-March, and it was so severe that in the space of 2 weeks, it turned the first quarter growth rate into a negative number. Continued into the second quarter with these large-scale job losses, 10 times larger than anything we've seen in a single month in U.S. history. So the onset is different. It isn't that people didn't have income. It isn't that we had a financial market disturbance. It was the virus, people hiding from the virus and not spending, and especially affluent individuals. So that's an important piece. For this hearing, one of the things that's happened is the health sector has never before been involved in the business cycle, and the health sector is the business cycle. Of the 5 percentage point decline in GDP in the first quarter, 2 full percentage points came from the diminished use of health services. People stopped going to doctors and hospitals and clinics. And what happens to the delivery system going forward, I think, is a very important question. We've seen a lot of consolidation in recent years. That's why prices are high. That's why insurance becomes expensive. And the ACA actually fostered some of that. Now we've got this enormous financial distress in the healthcare delivery system. That's going to be an important phenomenon. If there's less competition as a result, we're going to have a big problem.
Okay, thank you. And I see my time just expired. I appreciate your answers, and I yield back. Thank you.
The gentleman yields back. It's a pleasure to recognize the gentlewoman from California, my wonderful friend, Congresswoman Matsui, for your 5 minutes.
Well, thank you, Madam Chair, for calling this really important hearing, and thank you for the witnesses for being here today. And I just have to have a special shout out to Peter Lee as a wonderful Californian who's done a wonderful job. Let me just say this. The arrival of COVID-19, as we know, has quickly turned life as we know it upside down. And overnight, the pandemic created unprecedented challenges that necessitate rapid and extraordinary responses. California has been a leader in preserving and expanding access to care, and its pandemic response has been no exception. The ACA has been a lifeline for millions in California, and in our current crisis, the law has proven vital to ensuring that we can meet the increased need brought on by the recession. Mr. Lee, I want to follow up on the previous question regarding the special enrollment period for previously uninsured. How have you seen this special enrollment impact the risk pool, and what effect do you expect on premiums?
Great. Thank you very much, Congresswoman Matsui, and it's great to see you. I wish I could see you in person. Well, Covered California is more sensitive than anyone about the importance of a good risk mix. California, by enrolling more Californians than virtually any other marketplace, has enrolled healthier Californians, which means on average, our premiums are 20% less than they would have been. We engaged our health plans before we opened up the doors wide, and we saw 80% of the people signing up during the special enrollment period previously eligible, but more came in because we marketed. But 20% were not eligible previously, but they weren't people in ICUs because of COVID. They were people scared about getting COVID. They were people who were healthy, who we want to get tested. We saw those people come in, and we then assessed the risk mix. So I totally agree with the broad theory that Doug Holtze noted. In the early days of the ACA risk mix, we saw a healthier risk mix coming in during our special enrollment period. It's a win-win. You want people to not avoid healthcare during a pandemic, and we want to get more people enrolled healthier risk mix. It's going to lead to lower premiums, as in 2021, our plans have priced to have a 0.6% premium increase. That's because they look at risk mix, we look at risk mix. It's been a win-win, Congresswoman.
Okay, thank you very much for that. House Democrats have passed legislation to protect consumers and help make healthcare more affordable. We pushed for provisions in the HEROES Act, as been mentioned before, to establish an emergency special enrollment period and ensure access to free COVID-19 treatment. Unfortunately, the Senate Republicans refused to take this up. Dr. Aaron Dine, the ACA brought the uninsured rate to historic lows. However, under the Trump administration, nearly 3 million Americans have lost coverage. Can you discuss why the number of uninsured Americans began to climb? And also, what policies should we be putting forward to make it easier for people to get and stay covered in this and future crises?
Thank you. A number of policies from the administration, I think, contributed to the rise in the uninsured rate that we saw prior to the pandemic during a strong economy. But let me single out two. One is the set of administration policies, but particularly the public charge rule, which have really created a climate of fear for people, for immigrants and their family members who are eligible for public coverage programs, but are worried about what might happen if they enroll. And what we saw in the latest census data is that the groups you would worry would be most affected by that chilling effect, such as Hispanic people, children not born in the United States, were particularly likely to lose coverage. A second factor I would single out is the set of administration policies that have made it harder for people to get and stay enrolled in Medicaid. The work requirement policies that Dr. Summers spoke to were fortunately thrown out in court for the most part, but other policies have also created procedural barriers. For example, the administration actually told Idaho that it had to stop doing something that had made it easier for people to renew their Medicaid coverage and instead had to require more paperwork. And so going forward, I think some of the areas to think about to fill in the remaining coverage gaps include continuing to work on affordability policies, finding ways to make it easier for people to get and keep their coverage instead of harder, and creating more incentives for the remaining 12 states to expand Medicaid, which is just critical to fill in that major gap.
All right, thank you very much. And I know that my time is gone, so I yield back. Thank you very much.
I'm sorry. The gentlewoman yields back. Now it's a pleasure to recognize our colleague from Virginia, Mr. Griffith, for his 5 minutes of questions. Please unmute.
Thank you very much, Madam Chair. Can you hear me? All right, thank you. Look, you know, we've talked about the Supreme Court, and one of the things that I think hasn't been said is if the Supreme Court were to rule the ACA unconstitutional, that doesn't mean that there is a vacuum that cannot be filled. Congress, as civics teacher Shimkus would tell us, Congress has an opportunity to step in and fill that and act as it sees appropriate. And if we're so concerned about the pre-existing condition issue, how come we haven't brought up a standalone bill like Greg Walden's H.R. 692, which would take care of that and make it clear to everybody? Republicans and Democrats both believe that pre-existing conditions should be covered. And to Chairman Pallone's point, those who have had COVID may now have a pre-existing condition. Well, science is out on that. We're trying to figure that one out. And in fact, I've joined an NIH study to see, having had COVID, to see what are the subsequent consequences of having had COVID, and are there health conditions that may come from that 2 or 3 years down the road. And so we'll find that out, but we could fix that if we wanted to, and we have failed to act. Now let's go to the underlying ACA, and you know, I've said this many times, but it's still true. More than a decade ago, President Barack Obama visited Bristol, Virginia, my district, and in front of a large crowd, he proclaimed the virtues of his health care plan, which is now the Obamacare or ACA. Under the reform I proposed, if you like your doctor, you can keep your doctor. If you like your health care plan, you can keep your health care plan. He went on to say, under the Obama plan, the government would work with insurance companies to lower premiums by an average of $2,500 per family annually for those who have insurance. Well, here's what actually happened. According to Virginia State Corporation Commission of Insurance, there are currently 7% of Virginia's population is uninsured. Only one insurance company, only one, covers the 29 jurisdictions that I'm proud to represent. Only one. And in 2019, the weighted average insurance premium for individuals in Virginia was $796.29 per month. That's up from an average of $322.41 in 2014 and even more over 2010. My constituents feel the pain financially as well as physically. My office continues to hear about problems with the ACA and what those problems are causing. Even as the pandemic has caused more to need individual insurance plans. Since June of this year, we've had at least 54 separate complaints. Dr. Holtz-Eakin, is Virginia isolated in these experiences? Did the ACA fulfill its dream of allowing folks to keep their health care plans, keep their doctors, and lower their health insurance premiums?
No, your characterization is shared by many other states.
I appreciate that. And also, Dr. Holtz-Eakin, in your testimony, you discussed short-term limited duration plans as a potential stopgap measure for some people who have lost their employer-sponsored health insurance because of the downturn. You mentioned particular people who had previously made too much money to qualify on the exchanges when they went to enroll in their special enrollment period. Can you help me put into understandable terms, who would that be? How much money would someone like that have to have made, and what their choices in how much they pay in the ACA exchanges versus a short-term plan?
Well, you get folks making, $150,000 a couple, and they get hit with the downturn, and now what are they going to do? And so this is a degree of flexibility that was not present in prior years, and it gives people an opportunity to have insurance during what they hope is a relatively short recession and recovery. And then we've already seen job growth return to the United States. We saw that in May, June, July, August, and in the August report, we saw private payrolls rising at 20% annual rate. And so there are reasons to be hopeful that this will turn out to be a very limited, very sharp downturn, and then a short-term plan's the right way to ride that out and get back into your regular insurance after that.
Well, and I appreciate that, and the short-term plans can be helpful for some people. But let me underscore once again that while there's been a lot of discussion about pre-existing conditions, neither Republicans nor Democrats want to see people with pre-existing conditions not covered. And obviously, I've told you I had COVID. I'm one of those people that may be affected if Chairman Pallone is correct, and if the science bears out that there are some additional repercussions from having had even a mild case of COVID. We'll just have to see what happens in the science. But that neither Democrats nor Republicans are planning to get rid of the protection that is afforded to people who have pre-existing conditions. You would agree with that, wouldn't you, Dr. Holtz-Eakin?
Yes, I would. Both sides have put together proposals to preserve that protection. So there's no evidence that anyone's against it.
I appreciate it, and I yield back.
The gentleman yields back. I would just add to this discussion that on the Republican side of the aisle, not one member in the entire House of Representatives has spoken up and said that this case at the Supreme Court is going to wipe this out and that they are deeply concerned about it. So I just think it's important to place that on the record. I now am pleased to recognize the gentlewoman from Florida, Ms. Castor, for her 5 minutes of questions, and please unmute. Wonderful to see you.
Thank you, Chairwoman Eshoo. This is a very important hearing today on the Affordable Care Act and COVID-19. Thank you to our witnesses who are here. And Chairwoman Eshoo, you are right. Some of this rhetoric does not match the reality. We know it's crystal clear that President Trump and Republicans are urging the United States Supreme Court to strike down the Affordable Care Act in its entirety. That includes protections for 130 million Americans with a pre-existing health condition. And it also means the coverage for 1.9 million Floridians who purchase their affordable health insurance on the healthcare.gov marketplace. You heard that right. 1.9 million Floridians. That's more than the population of about a dozen states. So we have, the stakes are high here. And it's truly unconscionable that this would be urged on at any time, but especially in the middle of a public health crisis that has tragically claimed the lives of 200,000 Americans. Trump and the GOP are attempting to rip coverage away in the courts after they failed to do so in Congress, try as hard as they might. What they are doing by bringing this case to the United States Supreme Court is cruel and it is wrong. And in addition to actively putting the ACA's pre-existing condition protections at risk, President Trump and his administration have also recklessly expanded junk health plans. And the result has been that many bad actors have fraudulently sold junk plans to consumers. These junk plans often do not offer comprehensive coverage, and they discriminate against people with pre-existing conditions. In fact, this committee did an investigation and found that junk plans leave families on the hook for hundreds of thousands of dollars in medical bills, and they often deny claims for medical care that rightfully should be covered. In fact, the Federal Trade Commission has gone after some of these bad actors for their bait and switch tactics. There are a number of federal lawsuits filed against them, but the Trump administration has allowed them to proliferate needlessly. The Affordable Care Act was successful in limiting these junk plans and ensuring that families can rely on a meaningful health insurance policy when they purchase one. They don't want to go back to the bad old days when insurance companies could discriminate against them if they have asthma or cancer, now COVID-19. So I understand, Mr. Lee, that California has outlawed junk plans. Can you briefly explain why?
I can. Thank you very much for the question. I think there's a lot of confusion when people talk about short-term plans or faith-based plans. They're cheaper, they're a great option, they're short-term. Let's be clear, it's not just fraud. This is what health insurance was 10 years ago. These are plans that can, number one, exclude people based on their health status. So they went out people, but then there's no guarantee the coverage will be there when you're sick. It's Swiss cheese coverage. You don't know what's covered and what's not covered. And it's in there. They'll say, sorry, this short-term plan doesn't cover mental health. This one has a cap on hospital. They're a great deal. They're cheap if you predict the future. But if you can predict the future, you don't need insurance. You don't know if you're going to get cancer or end up in the ICU. And I'd note that in California, we have 800,000 people with unsubsidized coverage because we as a state have kept all the costs down. And that's been a failure of many states that have priced middle-class Americans out of coverage because they've allowed premiums to skyrocket by not marketing, not getting people in the door. Going back to short-term plans is a wrong solution. We have people come in and out of covered California every month. That's a working solution because when they're with us, if they get sick, they're covered.
So, Dr. Arendine, do junk plans pose a risk for families who contract COVID-19? What's going on here? What do you warn consumers about here?
Yeah, I do think they pose a risk to people who contract any serious illness. And I think there's a bit of a sort of myth out there that the people purchasing these plans are fully informed consumers making totally rational decisions to assume those risks. You could question whether anyone is able to make that kind of decision about those kinds of risks, but it's also clear that these plans are being marketed in misleading ways and that they engage, your committee report finds, in a lot of what's called ex post underwriting, which is a fancy word for finding reasons to deny people's claims once they get sick. So that's not coverage that people are making an informed decision to buy. It's coverage that's really leaving them without protection.
Thank you, and I yield back.
The gentleman from, the gentlewoman yields back. A pleasure to recognize the gentleman from Florida, Mr. Bill Arrakis, for his 5 minutes of questions.
Thank you so much, Madam Chair. I appreciate it very much. And thanks for holding this hearing. And I thank the witnesses for testifying as well. Like my colleagues on and off this committee and this administration, I too support protections for those with pre-existing conditions and funding our community health centers. However, like many Americans, I remain concerned with the continued high cost of healthcare despite the ACA's passage. Dr. Holtz-Eakin, one of the major promises of the ACA was affordable insurance for every American. The law even went so far as to penalize those who didn't enroll. However, in the decades since its enactment, costs continue to rise. Why is that, in your opinion? Why is that?
Well, I think one of the key features in across the United States has been increased consolidation in providers, hospitals buying up physician groups and the like, which allow them to have more market power and higher prices for delivering the underlying services. And insurance in the end is a product that just shifts the bill from one individual to another. If the bill's too large, insurance is going to be very, very expensive. And so I think that's been a concern among health policy experts of all stripes, that lack of competition and how to address the increase in prices.
Okay, thank you. Director Cameron, the pandemic has further stressed the mental health of our communities. I think we can all agree on that. Recent data from my district indicates increased overdose rates, unfortunately, this year, with August being one of the deadliest months on record. Congressman Soto and I introduced H.R. 5473, the Enhanced Access to Support Essential Behavioral Health Services Act, which builds on landmark opioid legislation passed by this committee last Congress to expand reimbursement for behavioral and mental health services delivered through telehealth, regardless of whether someone has substance use disorder. Would you agree that preventive measures like the EASE Behavioral Health Services Act would be helpful in addressing our nation's mental health crisis? And I believe that that was placed in Ann Wagner's bill, but we'd love to get that through this committee, but also on the floor of the House as soon as possible. What is your opinion on that particular bill, sir?
Thank you, Congressman. I have not seen the language, but I certainly believe that providing mental health services is paramount. We've been very successful in improving that through our telemedicine. In fact, that's been a real hallmark of what's happened this last year. Certainly support any efforts in that direction.
Yeah, people have to have access, no question. Again, Director Cameron, you mentioned in your testimony seeing an uptick in telehealth visits in Idaho. Pre-pandemic, some stakeholders cited a lack of clarity around federal reimbursement for telehealth of substance use disorders under Medicaid. Do you agree with that sentiment? And would additional guidance from the appropriate agencies at HHS be helpful to ultimately ensure that those who needed treatment can have access to it?
Well, certainly can't hurt. I think it's more complicated than that. I think people were not using telehealth services, because they weren't especially comfortable with it, and they got real comfortable real quick in the pandemic. I think providers weren't offering it because they weren't necessarily comfortable. They liked the old system of being able to see people face to face, and in many cases that's ideal. But one of the things the pandemic has done is it's sort of blown the doors open and allowed consumers to be able to access and utilize it. And I think many are saying they actually prefer it now.
Yeah, that's what we're hearing too, because they can actually do it in the privacy of their own home, and it's so very convenient. I have one last question, and I don't want to go over, Madam Chair. Dr. Holtz-Eakin, CMS released a report in August of 2019 on individual insurance market enrollment trends. Data shows that between 2016 and 2018, unsubsidized enrollment declined by approximately 40%. If the ACA has fulfilled its promise to provide affordable health care to all, why has this decline occurred? Is it an affordable issue, Again, thank you, Madam Chair, for allowing me to ask that question. If you could respond briefly, I'd appreciate it.
I think it is
Again, for Dr. Holtz-Eakin. Yeah.
I think it is an affordability issue by and large, and I'd be happy to elaborate in writing after the hearing.
Thank you very much. I yield back, Madam Chair.
Gentleman yields back. The recognized gentleman from Maryland, Mr. Sarbanes. Please unmute, and you have your 5 minutes for questions.
Thank you, Madam Chair. Can you hear me?
Very well.
Excellent. Appreciate the testimony today. Let's call a spade when it comes to the Republican attacks on the ACA. This has been an obsession for the Republicans for more than 10 years. The attack that's coming with the Supreme Court case in November and this effort to ram through the appointment of a new justice before the election is just the latest play out of that playbook that we've seen for years, which in my view is really just an effort to try to attack one of the legacy achievements of President Obama. But leaving that where it is for the moment, Dr. Lee or Mr. Lee, if you could describe, we've seen the Trump administration obviously engage in leadership malpractice when it comes to responding to the pandemic. And we could speak about the broad GOP reluctance to embrace the opportunities of the ACA over the last 10 years. But if you're in the middle of a pandemic, you start to see huge job loss that's disruptive to people's coverage. It seems to me that if there is in your toolkit something that you can do using the ACA and using the exchanges, and you don't take advantage of that, that is leadership malpractice of the highest order. Describe the moment when you pulled your team together to demonstrate proficiency in leadership in this moment. When you saw what was happening and you saw the amount of people that were being thrown into this place of not having coverage, that morning, that meeting, when you convened people and you said, here are the tools we're going to use that are available to us through Cover California because of the ACA to make sure we help people get through this crisis. What were the first 2 or 3 things you knew you had to do that unfortunately were not happening at the federal level?
Great. Thank you very much for that question. And, oddly, the first meeting we had was 6 years ago. It's not just about the pandemic. It's for the last 5 years saying we will do everything to make every Californian know we're there for them. And I think there's been failure of action both at the federal level since March, but also for the last 3 years. Cutting back on marketing spending, not supporting navigators, promoting short-term plans, which weaken the risk mix. But what we did this year, March 19th, our governor declared a state of emergency. March 20th, we declared a special enrollment period. And we've spent $9 million on advertising. And every day since then, when a Californian got an unemployment check, they got a flyer from Cover California. And our 500 storefronts across California were open virtually, taking enrollment by phone. And we promoted that. And it's a matter of saying, again, in America, there's 500,000 more Americans uninsured today because of federal inaction. Those are people.
Can you imagine? Thank you for that. Can you imagine if the president of the United States, in the midst of this crisis, had led with all the efforts that you just described at the national level, had gotten on the phone with governors across the country and states that had their own health exchanges and said, this is what we're going to do as a team to respond to this crisis. But he didn't do it. And now he's trying to take down the ACA in the middle of this pandemic once again. Let me turn to Dr. Summers because my head is exploding when I keep hearing my colleagues across the aisle talk reverentially about their desire to protect people with pre-existing conditions. But you can't just pull that out of thin air. I mean, there are actuarial dynamics to this, the way insurance pools function and all the rest of it that can allow you to do that effectively, i.e. through the mechanism that we've set up through the ACA, or to just try to pull it out of thin air, which is what I think their approach is going to be. Can you just talk to why if you really want to do that effectively, cover people with pre-existing conditions, you need to do it inside of a structure, an insurance structure and a coverage structure that actually makes sense and is sustainable.
Yeah, so states before the Affordable Care Act did try this, and what they found was that if they made rules that said you have to take all comers, but they didn't have the infrastructure of the ACA, they didn't have the tax credits and the subsidies, basically what happened was only 6 people signed up, premiums went through the roof, and the markets collapsed. You need the whole infrastructure of the ACA. You can't just put out that edict that says cover everybody.
Thank you. I yield back.
The gentleman yields back. Pleasure to recognize a gentleman from Missouri, Mr. Long, for his 5 minutes of questions. And please unmute.
Thank you, Madam Chair, and thank you all for being here today. Dr. Holtz-Eakin, much has been made of how the affordable health care is under the, much has been made of how affordable health care is under the current system. But can you talk about any trends you've seen that relate to the actual cost of care, not what the patients pay at the counter in the form of copay or coinsurance, but the underlying cost of care?
I think we saw in the 2 or 3 years in the aftermath of the Affordable Care Act, a noticeable diminishment in the pace of so-called excess cost growth, the rate at which healthcare costs go up faster than incomes in the United States. But more recently, we have seen that go back to something closer to the bad old days, an acceleration in those costs. A lot is made of prescription drugs, and particularly retail prescription drugs, but they are a small fraction of the healthcare bill. The vast majority of the costs are hospitals and doctors and other providers, and it's there that the attention needs to be focused if we want to slow the pace of the healthcare bill in the United States.
Okay, thank you. And Director Cameron, I understand that in Idaho, you offer a specific type of short-term plan that might be useful during the time period when folks may have a few months gap between their loss of the job-based coverage and the next open enrollment period. Can you talk about these plans and what kind of feedback you've gotten on them?
Certainly. Thank you, Congressman. So these plans should not be confused with traditional short-term plans. They are what we call as enhanced short-term plans. They're designed to be renewable. They have all of the same essential health benefits or requirements or coverages. They are not, as what one congressman's called as junk insurance. They have the same. They have the same pre-existing predictions or very similar pre-existing condition protections to an ACA plan, but they're available and allowed to be in enrollment year-round or at open enrollment if a person chooses to. They have provided an answer for us because we keep them in the same risk pool. So they're tied, their rates are tied to that of the ACA plans, and it helps attract and bring back those young and healthy individuals and families that need coverage, like the family in Oakley, Idaho, who the wife is a breast cancer survivor who knows the importance of coverage but can't afford $2,100 a month. They're cattlemen. Their prices change every day, and they don't qualify for a subsidy. So for them, they're being forced out of ACA coverage, out of no desire of their own, but simply because of price. This has provided an alternative for them that in essence helps all of those that are enrolled by keeping it in the same risk pool.
Okay, I might add that my sister has been a resident of Ketchum, Idaho for 40 some years now. So I don't think we're getting her back to Missouri. And do you regulate these products to ensure that they're marketed fairly and honestly to consumers?
Absolutely. We very strongly regulate them. We make sure, and by the way, I need to tell you, when I talked earlier about the traditional plans, waiving co-payments and deductibles and co-sharing for COVID, so did these enhanced plans. They did the same things, and we regulate to make sure that their advertisements are not misleading, that they fulfill the conditions of their policies, and we go after those that do so inappropriately.
So instead of issuing broad mandates and restricting plan design, Is it safe to say you've opened up the markets, collaborated with your health plans, and increased competition to make more choices available to your citizens?
Absolutely. Our goal is to have more people insured. The original goal of the ACA was to insure more people. And then some of the provisions actually started limiting who could actually obtain coverage. So our goal is to have more people insured. We've collaborated with our carriers. We'll now have 3 carriers offering these type of plans this coming year.
During the pandemic, you've had plans set up and volunteered to offer credits back to consumers, make advance payments to providers to help get them through the downturn?
Yes, sir.
And what effect have these policies had on premiums for your citizens?
Well, in many cases, they've actually lowered the price of where they were previously. One of our carriers lowered the price by 50% on dental premiums. Others lowered it by 15% over this next year. What's happened is that we don't have as many people taking advantage of treatment that wasn't as necessary, and so the amount of claims being spent has dramatically decreased, and so they've been refunding that money back.
Okay, Madam Chair, I don't have any time to yield back, but if I did, I sure will.
The gentleman yields back. I would just like to say to the witness from Idaho, it would be, I think, instructive for you to read the June 25th report that the Energy and Commerce Committee put together that found short-term plans denied and rescinded coverage for millions of people. And after reading that, I would look forward to your kind of written response to it. But I do think that it would be instructive. It was highly instructive to me. Now it's a pleasure to recognize the gentleman from New Mexico, Mr. Lujan, for his 5-minute questions.
Thank you, Madam Chair. Before I begin my remarks, Madam Chair, I do have a unanimous consent request.
Would you please state it?
That's to submit a GAO report, the U.S. Government Accountability Office, August 2020, private health coverage results of COVID testing for selected offerings.
The unanimous consent request is approved. It's already part of the record. And at the end of the hearing, I will name everything that's been placed in the record.
Thank you, Madam Chair. Not sure if my clock can be reset. But nonetheless, Madam Chair, the reason that report matters so very much is when you go into the summary findings of that report, what the GAO found is when they were out there looking at folks that were selling what my colleagues on the other side of the aisle are calling short-term plans, that I've heard everyone else call a junk plan, they found that there were deceptive marketing practices similar to the findings from the Energy and Commerce Committee. And what's clearly listed here is that those short-term plans, the plans that I refer to as junk plans, they do not cover people with pre-existing conditions. People need to stop lying to innocent folks that are out there and convincing them that these plans are going to cover their cancer, their diabetes, or if they get in an accident. Many of these plans don't even cover prescription drug costs. They don't cover ambulatory care. Enough. Let's just be honest. If you want to sell people these short-term junk plans, let's be honest with the American people as to what they're buying. So that way people are not left without. That's all that we're saying here. Truth and transparency. Why is it that the Trump administration eliminated the requirement on those junk plans to list exactly why they were so bad? I have screenshots from superintendent sites across America before President Obama's administration, before President Trump's administration changed that rule and after, and you see the disclaimers change. But that's a conversation for another day, Madam Chair. At this very moment, the Trump administration and Republican governors and attorney generals are leading efforts with the U.S. Supreme Court in a case where they're seeking to strike down the entire Affordable Care Act. They aren't asking the U.S. Supreme Court to keep the parts they claim they like, such as protections for people with pre-existing conditions. They're asking the Supreme Court to strike down the whole lot during a public crisis that has taken the lives of more than 200,000 Americans. If the ACA is struck down, protections for people with pre-existing conditions would be gone. That now includes the nearly 7 million Americans who have been infected with COVID-19 who could be denied coverage for the rest of their lives. More than 20 million people would lose their health care coverage, including 226,000 New Mexicans, more than doubling the number of people in our state who are uninsured. The 9 million people who receive subsidies to make their premiums more affordable would be on their own. In the middle of a state budget crisis, states like New Mexico would be left to shoulder the full cost of keeping people covered through Medicaid. Now, remember that bill that Republicans tried passing in 2017? That actually eliminated every dollar with the federal government's investment in Medicaid. Private insurance plans wouldn't have to cover preventative care, maternity care, mental and behavioral health, and other essential services. Young adults could no longer stay on their plans until the age of 26. And insurance companies could go back to charging you more just because you're a woman, you have a health issue, or because of your age. My Republican colleagues have no plan to cover the pre-existing conditions or to protect the American people. Their last proposal from a few years ago allowed insurance companies to charge ridiculous prices for people with pre-existing conditions. It slapped an age tax on older Americans, and it forced states to ration care by drastically cutting Medicaid. President Trump has not put forth a plan at all, although he's promised it for 4 years, every 2 weeks. But what we have seen from him already is deeply troubling. The Trump administration has promoted those junk plans that we were just talking about, which look cheaper until you get sick, and realize the plan doesn't cover basics like emergency room visits or prescription drugs. Now, Madam Chair, I have a couple questions. Dr. Arendine or Dr. Summers, in both your testimonies, you talk about how Trump administration policies have chipped away at coverage gains achieved during the first few years of ACA implementation. Would either of you like to comment on short-term, limited duration junk plans or other Trump administration efforts to sabotage not just the number of people covered, but the quality of coverage?
Sure, I'm happy to answer that. I think there are a couple of issues that I highlight. The first is that people have to know about the coverage and be able to navigate the system to get it. And if you make the period that they can sign up shorter, spend less money on outreach and less money on assisting people with those applications, they don't get covered. These are my patients. They struggle with the complexities of our healthcare system. If you make it harder for them to sign up, a lot of them won't. The other thing I'll just say is that this is not a story where some states really suffered under the ACA. We've heard numbers that maybe Idaho or Virginia, other places have suffered. Well, the numbers are, in Idaho, 100,000 more people were covered in 2016 compared to 2013. In Virginia, 300,000. In Florida, 1.6 million. Every single state in the U.S. experienced substantial increases in coverage under the ACA.
And Dr. Arendine, what would striking down the ACA mean for Medicaid and state budgets?
As a starting point, it would eliminate Medicaid expansion, which covers 12 million people not eligible under pre-ACA law. It's incredibly implausible that states could continue to cover those people who rely on that coverage. It would also undermine Medicaid in a host of other ways.
Thank you, Madam Chair. I yield back.
The gentleman yields back. And now I'd like to recognize the gentleman from Indiana, Dr. Bouchon, for your 5 minutes of questions, and please unmute.
Thank you, Madam Chairwoman, and thanks for holding this very important hearing. First, I'd just like to say, Republicans want people with pre-existing conditions to have health coverage. I think really what we're talking about is people that are high-cost individuals that otherwise couldn't afford coverage before the mandate was put in place. But one of the biggest flaws of the Affordable Care Act is the way to solve this issue was done in a way that has resulted in dramatically increased costs for everyone. Republicans have a health care plan that will cover people with high cost medical care, pre-existing conditions, but will allow others to get more affordable health coverage by putting those high cost individuals in a separate insurance pool. Anyone that understands insurance knows if you put high cost individuals in the same pool as everybody else, everybody's cost goes up. As a provider, I had patients with pre-existing conditions, high cost health problems, and that couldn't get insurance, and that's just wrong. We want to solve that in a different way. So it's really not a good narrative. It's a false narrative that we don't. Dr. Holtz-Eakin, in the GAO report that was just discussed, were there any of the short-term limited duration plans found guilty of false marketing?
I'm not intimately familiar with that, but I'd be happy to get back to you after reading it.
That'd be great. And also, I've seen some comments that in the press, people saying the Republicans are undermining the Affordable Care Act, a lot of it tied to repeal of the individual mandate. But I'd like to ask you whether you agree with that sentiment or whether you agree with the recent story from the New York Times that ran the headline, and this is the actual headline: Republicans killed the Obamacare mandate. New data shows it didn't really matter.
So this has been a long debate among researchers as to just how much the mandate was effective in getting people into the ACA insurance. And I think the Congressional Budget Office in particular has rethought the effectiveness of the mandate. It really wasn't as effective as people had thought. Instead, they point to some things that have been mentioned in this hearing, which is marketing, navigators, the kind of outreach that recruited people and got them into the ACA. That was a bigger part of the story than the mandate.
Yeah, I mean, I think, thank you for that answer. I think the issue was, from my perspective, is that the federal government was mandating the American people purchase a product, which in this case was health insurance. And as you pointed out, the American people don't necessarily follow federal mandates, and because we believe in individual freedom and individual choice. As a follow-up, I've seen also a lot about how the administration has depressed enrollment in the ACA exchanges, but what about the health reimbursement accounts rule that the administration finalized last year that would let employees use their health care benefits to purchase coverage on the exchange? Wouldn't that actually increase the number of people who might join the exchanges in the coming open enrollment period?
Certainly when the administration put out that rule, they had estimates of large-scale take-up, a very large-scale take-up of those HRA provisions. They haven't been in place long enough for us to see if that comes to fruition, but it's a big change in the opportunities that people face.
Thank you for that answer. So I think, this has been a good hearing. I have one more question. I think I have about a minute left. Director Cameron, as a provider and member of the House Doctors Caucus, I was encouraged to hear about your work with health plans in Idaho to extend various forms of financial assistance to providers who were suffering during the pandemic. Can you expand on the specifics of what plans did and what the effect had on access to health care in Idaho?
Certainly. Can you hear me? Thank you.
I can.
So I'll just target or just list a few of the things that they did without naming specific companies. Again, we have 5 carriers, unlike many states who are down to 1. We had targeted loan programs. Obviously, all of the carriers were processing their claims quicker and suspending prior authorization restrictions. $1.4 million was given by one company in cash advances to select provider groups. 3 of our carriers banded together and gave another $5.5 million to providers in a specific hospital system. And another carrier offered $10 million in interest-free loans or cash advances to providers in order to assist them in getting through this pandemic.
Thank you very much. I'd just like to say finally that, as a provider, I want everyone that has high-cost health problems, so-called pre-existing conditions, to have affordable health coverage. I just believe that it needs to be done in a different way because the way that it's been done in the ACA has increased the cost for everyone in the system. We can do it in a better way. With that, I yield back.
Dr. Bouchon yields back. We thank him. And it's a pleasure to recognize the gentleman from Oregon. Mr. Schrader, you have 5 minutes for questioning, and please unmute.
Thank you very much, Madam. Yeah, thank you very much, Madam Chair. Appreciate the opportunity here and appreciate the panelists. I would agree with my good friend and colleague from Indiana that the individual mandate has not been as important as we had originally anticipated. But as our good friend and colleague from California has pointed out, Mr. Lee, that the outreach is, and that's important. That has been curtailed, unfortunately, under the current administration, and caused some problems over the last couple of years. Hopefully, one of the few good things comes out of this pandemic is the fact that people are now realizing that healthcare is an opportunity. They have access. It's been pretty amazing to me that we have not had a huge uptick in uninsured people as originally expected. Mr. Holtz-Aiken, you testified that there are basically three elements that have contributed to that, some special enrollment periods and ability to utilize the ACA, some of these short-term plans, and COBRA coverage. Do you have any feel for which of those has contributed more or less, or what the rough percentages are that each of those options contributed to keeping people insured?
Yeah, I don't have any firm data on that. It's quite frustrating trying to sort it out. My instincts are that the COBRA has been the least important, and that we've seen people go Medicaid, ACA, and then perhaps some short-term plans.
Okay. Yeah, and a testament to, I think, American healthcare system. It's not a one-size-fits-all. We have many options for folks that are out there, depending on your personal circumstances and your personal inclinations about how you want to get healthcare. I have a bill actually with a colleague Rodney Davis from Illinois that talks about COBRA coverage and making it hopefully a better option. I would hope the committee and Congress would consider this as one of the things in the mix by making sure that it pays at least what the premium for that employee that would have been covered under that employer-sponsored healthcare program, to make it, at least during the pandemic here, make it so that there be an option. Do you think, Mr. Holtz-Aiken, that that would be an incentive for COBRA to be a more effective help for keeping people insured?
Well, as I said in my opening remarks, one of the advantages to COBRA is it avoids the churn that was mentioned by Dr. Simmons. And churn comes with the downside that you're often changing provider networks and your care gets disrupted. And that's the last thing you want in the middle of a pandemic. So sort of getting people to stay on their insurance using the COBRA augmentation is a way to avoid that entirely. And one of the difficulties for everyone, the experience of the American worker and for policymakers, is that we just cannot get a good firm handle on how many of the job losses will turn out to be temporary. Of the 20 million we got in April, 18 were reported as temporary layoffs. Some others are going to turn into permanent job losses. And so, which vehicle you want to use, if you're permanently going to lose that job, you might think very differently than if you're just temporarily laid off. It's been a real struggle thus far.
Thank you. Thank you for that. Mr. Sumners and Ms. Arendine, I question on do you have any feel for what the socioeconomic makeup is of those people that are using these special enrollment periods to sign up for healthcare? Is it reflective of the population writ large, or is there some difference there?
Certainly, in general, use of the marketplaces is concentrated among moderate income people, and job losses have also been really concentrated among low-wage workers, which is a consideration in thinking about COBRA. A big problem is a lot of the people losing their jobs may not have a COBRA option, particularly lower-income workers, particularly workers of color, who are especially vulnerable to becoming uninsured.
And I would just add briefly that in addition, when workers might have had a plan that worked well for them when they had a higher income, if they become uninsured and lose their income, those co-pays from their employer coverage may no longer be adequate for them, and Medicaid may provide much better protection for them in terms of being able to get the care they need.
So it sounds like we need an all the above option like we've got currently in this country with the ACA and COBRA coverage and what all even the short-term plans for a very short period of time. But as pointed out by a lot of my colleagues, they do not offer a long-term option in terms of complete benefit protection. And we got to keep that in mind as we go forward. Now I yield back, Madam Chair. Thank you.
The gentleman yields back. It's a pleasure to recognize really just a superb member of our subcommittee. We are just going to miss her. The gentlewoman from Indiana, Ms. Brooks, you have 5 minutes, and I hope you're unmuted.
I am, Madam Chairwoman, and thank you so very, very much. And in fact, I'd like to take this opportunity to thank you, to thank the ranking member and my colleagues. First, I want to thank the witnesses for being here. And while this is an incredibly partisan hearing, so many in my 6 years of being on the subcommittee, I just want to remind the committee, we've accomplished incredible things, and there is still a lot more of incredible work to do on behalf of the American people. And the Energy and Commerce Committee, and particularly the Health Subcommittee, has an incredible track record. And I know we are working on this incredibly difficult issue of the ACA, or better ways to provide healthcare for all Americans and affordable healthcare. But I just want to thank you, because I've been able to be a part of, this is my last hearing in all likelihood, been able to be a part of the 21st Century Cures, able to be a part of CARA, able to be a part of PAPA. I could go on with all the acronyms, which most Americans don't know much about. But you all know, as members of the committee, the important work we've done on opioids, mental health, healthcare affordability. There is so much and preparing and responding for this pandemic. But there's a lot more work to do. And I just want to encourage all of you. I want to thank the staffs also. We have incredible staff. I've worked with really great staff on both sides of the aisle, and just want to thank them for their commitment in helping us find even better ways to work together. I'm on the Select Committee on the Modernization of Congress, and we're going to be rolling out our recommendations as we have been. And I just want you all to know that this completely bipartisan committee has more recommendations, which I hope that the body takes up, because we all have to do better to find the common ground. And I actually believe we have a lot more common ground, and we can find more common ground if we just continue to really work together, talk together, it's difficult, I understand, in COVID and with us working remotely. But, you know, whether it's picking up the phone, I love that Kurt just mentioned that he's working with Rodney Davis on something who's not even on the committee. We've got to find ways to keep working on all of these really incredibly important issues that this committee works on. So I want to encourage you all. I have great hope, and we've got to get through this for our citizens and our constituents. When it comes to COVID, obviously healthcare has never been more important, and we're right in the middle of it. But it's the innovation that's come from our incredible health companies in this country, we've got to continue to support. I'm really proud of the fact that we have been able to do a lot without expanding Affordable Care Act. Insurance companies have committed to providing COVID tests, patients free of charge. We're bringing our supply chains back. That's critically important. I am concerned that COVID, all these patients that have had it, all these citizens will have a pre-existing condition, and we have to and must, and we are committed on both sides of the aisle to covering pre-existing conditions for all Americans. And now we have, you know, millions of people who've tested positive for COVID, and that we've got to make sure we get this right. In my brief time I have left, telehealth is one of those amazing things that we've talked about, but now we're doing. Mr. Cameron, can you please share with us the dramatic increase in telehealth visits your state has seen? What are areas where it's been incredibly successful? Where are areas where maybe we shouldn't be focused on telehealth? I know it's great for mental health, but I talked to some dermatologists this week where it's really tough in dermatology, for instance, for telehealth to be incredibly helpful. So can you talk to us in my brief time I have left? But I do want to thank the committee before Mr. Cameron answers. I have great hopes for you all, and I've loved working with all of you. Mr. Cameron?
Thank you, Congressman, and thank you for your service, and thank you for your comments. Telehealth has been in an infancy here in Idaho, and not really a lot of take-up. Mostly, I think, because a lot of providers, and as I said earlier, some consumers did not want to take it. I myself see a dermatologist, and it's an interesting story that you shared. I actually, while in the state capitol building, did a dermatologist visit with my phone to go over some of my issues and show some of my concerns. So it can be done, but there still has to be some hands-on follow-up. There are some health conditions, without getting into provider codes, where it doesn't fit really well. And so those need to be talked about. But we need to provide the services and the tools and the technology so that it can happen. I think consumers, as was said earlier, now actually prefer telehealth to other forms of coverage. They'd rather have a telehealth visit than go to the emergency room unless it's really dramatic.
Well, thank you. And to my committee members, we have to continue to support and expand telehealth and help. And I know everyone wants to help all Americans with their healthcare needs, especially right now. Thank you, Madam Chairwoman. I yield back.
Well, thank you for yielding back. And when you speak, you make all of us fall in love with you all over again, which then leads to how much we're going to miss you. And speaking of missing people, it's an honor to recognize the gentleman from Massachusetts, a really extraordinary and thoughtful member of the subcommittee. Such value added, not only at our committee, but the entire Congress. The gentleman from Massachusetts, Mr. Kennedy.
Madam Chair, thank you.
I love.
Thank you. Grateful to you and to all the members of the committee. I will follow Ms. Brooks' example here briefly. This is in all likelihood my last committee hearing as well. It has been an extraordinary honor and pleasure and privilege for me to join all of you on the best committee in Congress, to work with all of you on both sides of the aisle to try to advance the interests of the American public. And to the incredible staff and committee staff here, a huge hats off to you, again, both sides of the aisle, for your work and collaboration and the effort that we've made together. It has been an enormous privilege for me, and I wish you all well going forward. And a number of big issues on the agenda to tackle, including the one obviously before us today. And I want to thank all the panelists for being here, for your work, and for appearing once again before the committee. Beyond the horrific loss of life caused by this pandemic and the administration's failed response, the economic consequences of job losses, business closures, and looming evictions will last for generations. The national employment rate has more than doubled since February, and in states like Massachusetts, it still remains stubbornly high. Losing your job can mean much more than the loss of income. It can also mean the loss of health insurance. And this is very much a life or death situation for the millions of people with chronic health conditions, for parents of children with complex medical conditions that require constant monitoring and treatment. Fortunately, for millions, Medicaid provides them with continuous quality health insurance so that they don't have to worry about getting the care that they or their children need. So, Dr. Arendine, I want to start with you. What can you tell us about Medicaid enrollment since the beginning of the pandemic?
It's risen, just as you would expect would happen, since Medicaid is supposed to be there for people as they lose their jobs or see reductions in income. Medicaid enrollment is up 8% generally, and up more in Medicaid expansion, which targets some of the most vulnerable people.
Right, and other parlance is countercyclical, right? When you have an economic downturn, Medicaid enrollment increases, right?
Exactly, which helps people and also helps the economy.
Right, thank you. So I understand that many experts predict that Medicaid enrollment will continue to climb, and I'd love to get your thoughts as to why that might be.
I think that's likely. Even in a quote unquote normal recession, Medicaid enrollment often lags a little bit because signing up is not the first thing people do. And in this recession, as others have talked about, people haven't been seeking medical care because of the pandemic. If they have healthy people haven't been seeking medical care. And that's often a mechanism by which people get enrolled in coverage, is they go to a CHC and they get signed up. So if they're not doing that, they may not have gotten signed up yet.
And Doctor, you touched on this already a little bit, but just flesh this out for us a bit more. How has Medicaid expansion specifically helped states to respond to the current unprecedented health and economic crisis?
Sure. I mean, we've talked about how it's there for the people who are newly losing their health insurance, but I think it's equally important that millions more people, 12 million more people, are covered through Medicaid going into the pandemic than would have been without expansion. And there's at this point just a lot of research showing that it's improving their health, improving their financial security, reducing evictions, and actually saving lives. And in fact, has been especially important to people with pre-existing conditions for whom it's enabled them to get regular treatment for chronic conditions for the first time.
We had a Medicaid director, I believe from North Carolina, testify before the committee several months ago, back when we could do in-person hearings. And he actually testified, if I remember correctly, that they had determined that the ACA had saved literally hundreds of lives in North Carolina through Medicaid expansion. And given that, I think a lot of us obviously are incredibly concerned that once again, the Affordable Care Act is before the Supreme Court, and the Trump administration is urging the justices to throw out every aspect of the law. So despite what some have argued today, that is literally the legal brief that has been filed by the Trump administration. So, Doctor, I'm not asking you to read too far into the tea leaves here, but if the Supreme Court agrees that the ACA is unconstitutional, what happens to the 13 million Americans currently receiving health insurance through Medicaid expansion?
Medicaid expansion would be eliminated, and I think it's likely that the large majority of those people would become uninsured and lose that access to care and financial security.
And what happens then in the midst of, for those folks when, if that does take place, in the midst of a flu season, an unknown yet impact of another COVID-19 winter, and the economic prospects of recovery?
I think the pandemic has reminded all of us that it's very important for people to have health insurance for their own sakes, but also as a matter of public health.
Yeah. Doctor, thank you. COVID-19 has brought about unprecedented challenges to our healthcare system and our economy. And it's clear from the witnesses' responses that Medicaid has played a vital role in responding to this crisis and ensuring that adults and children continue to have access to the care that they need. However, for millions of Americans, that safety and security hangs in the balance if the Supreme Court sides with Republican attorneys general and takes healthcare insurance away from 20 million people in our country. Doctor, thank you very much. And Madam Chair, I yield back.
The gentleman is back. I now would like to recognize the gentleman from Georgia, Mr. Carter, for your 5 minutes of questions. Please unmute. Mr. Carter there? Paging Mr. Carter.
I am here. I didn't know I was next. I apologize.
That's all right. Your 5 minutes.
Well, thank you. And thank all of you for joining us here today. I appreciate everyone who's been on the panel. And I certainly would be remiss if I did not also offer my congratulations to Representative Kennedy, Representative Brooks, and all the other members of this great subcommittee and great committee who are going to be leaving us. We're going to be losing some valuable members with great institutional knowledge, and we certainly will miss all of them. Madam Chair, I want to begin by addressing the situation that continues to be a problem. And that is, my colleagues across the aisle seem to want to communicate or seem to want to put a message out there that Republicans are not wanting to protect pre-existing conditions. Nothing could be further from the truth. And I think you all realize that. And that is something that we have worked on and we continue to work on. In fact, if we look at the present Congress that we're in, the 116th Congress, one of the first 4 votes that we tried to have was to try and protect those with pre-existing conditions. So I want to reiterate what's been said by a number of my Republican colleagues on this subcommittee here today, and that is that we are in favor of pre-existing conditions. We continue to be, we have been, and we will always be. We understand, particularly in the trying times that we are in now with the problems that we're having with the pandemic, we understand how important covering pre-existing conditions are. Dr. Holtz-Eakin, in your testimony, you mentioned that through June, there were 6.2 million workers who lost their employer-sponsored insurance due to job loss from the pandemic. And President Trump has worked to make short-term limited duration plans available to beneficiaries for up to 36 months, providing certainty and continuity for patients. Previously, the previous administration had made them available for only 3 months. How can short-term limited duration insurance plans fill the employer-sponsored insurance gap? And is there any indication that they have?
So as I mentioned earlier, we don't have a great data on what's happening on the ground right now. So I can't answer with any sort of definitiveness how many people are taking up short-term plans versus other options. But it is another option on the table. It's an option that was not available previously. It might hit a price point that is better than a price point on the say marketplace, and that would be a very valuable option in this situation.
And wouldn't you believe that it would offer patients more flexibility and affordability in coverage?
Certainly, there's a greater variety of plan designs out there. That's one of the advantages The concern that you've heard voiced is that people won't understand the plan design they're buying, but certainly there ought to be a way to do good consumer education, get them in a plan that's good for them.
Well, I believe this committee in general has addressed that before. In fact, I know that I have advocated for us to publicize these plans more so that people would be educated as to the availability of these plans and how they could help them. But unfortunately, the other side of the aisle, again, are opposed to these plans and did not want to offer education to our citizens as to the availability of these plans. Let me ask you also, Dr. Eakin, given that premiums have more than doubled during the time that the Affordable Care Act was signed into law, what are your recommendations for how we can reduce the cost of health insurance and allow people to shop for coverage that might best fit their needs?
Well, there are really two broad strategies. The first strategy is to provide greater competition in insurance markets, lower the barriers to entry, allow more products and variety, and allow people to choose among them and thus get a plan that fits their economic situation. The second strategy is to deal with the underlying cost and value proposition in the delivery system. And certainly there's a lot that Congress can do in that area through the big payment silos that are in Medicare and Medicaid, which really drive the delivery system in the United States. And some of it can be done at the local level, state scope of practice, state certificate of need, all sorts of limitations on competition need to be addressed. I think the telehealth example is the best example of how the overregulated U.S. healthcare system couldn't respond flexibly to the pandemic. And it was only the emergency waiver of a lot of regulations that allowed telehealth to prosper. That should be made permanent. I mean, that's going to require legislation. That's a great opportunity going forward. And I'd encourage the committee to look at that.
So you would agree, just as the free market has worked in our society, that the free market can work in healthcare to lower healthcare costs?
Certainly, if you have high prices, you have a supply problem. And you ought to look at the conditions that are limiting supply.
Well, thank you very much. And thank you, Madam Chair, and I'll yield back.
Thank the gentleman from Georgia. He yields back. Now it's a pleasure to recognize the gentleman from California, Mr. Cardenas, for your 5 minutes of questions. Please unmute.
Okay, I should be unmuted. Can you hear me?
Yes, very well.
Okay, thank you so much. Thank you, Madam Chair, and appreciate the opportunity for us to have this important hearing. I want to thank all of our folks who are here to give us their opinion and expertise to be before our committee. I also want to say thanks to the ACA, approximately 20 million Americans have gained coverage through the law's various coverage protections. 9 million low and moderate income Americans receive health insurance subsidies to make their health care more affordable. 130 million Americans are allowed to receive coverage without being discriminated against by the insurance companies, and made sure that by law, the Affordable Care Act law, they have the right to coverage even though they have a pre-existing condition, and they cannot be charged a penny more than anybody else who's getting the same coverage. In an unprecedented and nakedly political decision, the Trump administration declined to defend the Affordable Care Act, otherwise known as the ACA, in this Republican lawsuit that is seeking to declare the entire law invalid. The Trump administration is continuing with this extraordinary decision in the middle of a pandemic that has claimed the lives of now over 200,000 Americans. If the lower court's ruling is upheld, millions of Americans would lose their health care overnight in the middle of a global pandemic. I'd like to ask some questions first to Dr. Arendine. Dr. Arendine, how many Americans would lose coverage if the decision were upheld shortly?
Prior to the crisis, the estimate was 20 million, and that number would be larger today with more people turning to these programs for coverage.
Thank you. Could you discuss the impact of the court's decisions on Medicaid expansion?
Medicaid expansion would be eliminated, meaning that the 12 million people who are newly eligible because of the ACA's Medicaid expansion could lose their coverage, would likely become uninsured. It wouldn't be there for people newly losing their jobs and their coverage in this recession to turn to. And state eligibility would presumably revert to the pre-ACA levels, where few parents and almost no adults without children were able to get coverage.
So I think you just described that the Affordable Care Act law, once it became implemented, and still to this day, millions of Americans are actually being able to see doctors, getting healthcare basically, that before were either struggling or not receiving healthcare.
That's exactly right. And we have direct evidence of that, including from some of Dr. Summers' research, that people are getting prescriptions filled, they're getting treatment for chronic conditions, and that the ACA's Medicaid expansion, as well as the marketplace coverage, have been literally life-saving.
And this is also would be affecting working families with moderate and low income.
Absolutely, particularly if you look at coverage for the people who we now refer to as essential workers. Many of them get their coverage through Medicaid, especially in expansion states, and that would be wiped out.
So one thing I'd like to clarify, did the Affordable Care Act only increase the availability for healthcare for unemployed people who are not working, or did it in fact increase by millions or not, being able to have access to healthcare for working families?
I'm not sure I understood your question, but
let me clarify what I mean, Doctor. A low-income family is probably a family that they have low income. They're actually working, but they are, say, at minimum wage or what have you. So therefore, providing healthcare for them and their children, for example, is very difficult because they otherwise can't afford it. And the Affordable Care Act has implemented an opportunity for them to actually get healthcare, even though they're low income, whereas before they could not go out to the market and get it because they just couldn't afford it.
If I can jump in briefly, as described in my testimony, we actually have looked at this issue of working families, and the ACA's biggest coverage gains are in blue collar families. These are people in construction and mining and agriculture and service jobs where they don't get coverage through work. So you're exactly right, Representative. This is a key feature that the ACA has helped working families substantially.
Yes, thank you so much. I'm sorry my question wasn't that clear, but I appreciate the clarity and the answer. And then also, isn't it through the ACA now, young adults can actually stay on their parents' coverage up through the age of 26, whereas before that was not a typical coverage from the insurance industry?
that's correct. That's a nationwide protection put in place by the ACA, and it's one of the reasons that young adults would see especially large coverage losses if the law were struck down.
Yes, thank you. My time is limited, and even though the clock stopped, what I'm going to do is I'm just going to close by saying that I'd like to thank you, Doctor, and also everybody testifying today, and just remind everybody that the truth is that the Republican lawsuit would have disastrous consequences for our nation's most vulnerable Americans. Yes, Madam Chair.
Thank you. The gentleman yields back. I understand that Dr. Burgess has joined us. Are you actually there?
Yes, I am, and unmuted.
The chair recognizes the ranking member of the subcommittee, Dr. Burgess, for his 5 minutes of questions. Glad to us.
I thank the chair and thanks to the committee's understanding on a morning where there's a lot of multitasking going on, where our time in town may be limited. There's a lot going on, as I'm sure everyone is experiencing. I would ask, Madam Chair, that my entire opening statement be made as part of the record.
So ordered.
And Dr. Holt-Eakin, welcome to our subcommittee. Thank you so much for participating with us today. I just note, on the issue of employer-sponsored insurance, and I think you talked about this in your testimony. Well, employer-sponsored insurance, right, pre-pandemic levels had actually increased significantly in the years since President Trump had taken office. I think it was in excess of 3 million more people had the availability of employer-sponsored insurance. So those employer-sponsored plans, now that we're in a situation where people are losing employment, what is the options that are available for someone who's lost coverage on an employer-sponsored insurance? They can sometimes get coverage on another family member's ESI plan. Is that not correct?
That's correct. Their spouse could be covered and they could acquire coverage that way.
So I guess then the question comes up, how has our existing safety net system worked as intended to catch people that got hurt during the pandemic?
The safety net really consists of the COBRA options that people have, the ACA, a place where they can, if they've lost employer insurance, they can go and enroll in a plan, and the Medicaid program. To date, I think that safety net has held up pretty well. As I noted in my written remarks, the Census Household Pulse Survey shows no strong trend in any direction on coverage, and that's not attributable to any single program, but to the collection of all of them.
Okay, well then, particularly appropriate to this subcommittee and this committee, are there any flexibilities that Congress has not provided to states and their insurance plans that would improve the uptake of other options?
I think that something that would be really valuable for the committee to look at is to look at the waivers that have been provided by the administration on regulations that are due to the emergency, the declaration of the emergency. They have authority to waive an enormous number of things. Like I mentioned with the telehealth, you can use a commercial device, use FaceTime, a waiver of the protection against minor HIPAA violations for anything disclosed over that. That allowed people to actually stay in their homes instead of going someplace to do telehealth, which doesn't really make a lot of sense. And all that will go away when we thankfully get past the pandemic. But there's a lot of that I think ought to be in law, and Congress should look at in providing flexibility. We really learned that the U.S. healthcare system couldn't do two things at one time. It couldn't treat COVID-19 and continue to provide ordinary care. And that, I think, was quite revealing about the sort of overregulated lack of flexibility.
Yeah, I'd certainly echo the overregulated lack of flexibility. Much of the curtailment of practice was actually a result of governmental direction where trying to preserve capacity in an emergency room or ICU setting, hospitals were, and medical practices and clinics were required to reduce their workload of elective procedures, which subsequently killed their cash flow and has made it very difficult for them to recover. Dean Cameron, just ask you a question about populations of people are different, and arguably Idaho and New York are significantly different. So the flexibility for states to develop plans that actually fit a state's population's needs is important. So could you perhaps provide us a little further detail about how Idaho insurance companies waive some of their eligibility requirements to make it easier for beneficiaries to maintain their access to high quality care?
Yeah, absolutely. And thank you for the question. As I mentioned in my remarks, we started meeting with our carriers and trying to talk about how we help citizens, how we keep them from being forced out of coverage, how they can access the special enrollment periods, how we can make that transition even easier. And we pointed to and found a number of provisions in state law and even in some rules that didn't seem to make sense at the time. For example, we had employers say to us, well, I've laid off my folks, but now I want to hire them back, but I don't want to go through a new eligibility period. Well, it didn't make sense to do that. So we essentially issued bulletins working with our carriers saying we're not going to do that. We issued bulletins allowing carriers to keep people that are furloughed on their plans even longer. State law said that you had to be employed at least 20 hours a week in order to qualify for small group coverage. We waived that. There were a number of provisions that way that in sitting down and collaborating with our carriers decided in this pandemic that wasn't appropriate. We want people to have coverage, and we did everything we could to help them keep coverage.
Well, thank you for that. I see my time's expired. I have a couple of additional questions. Madam Chair, I'll submit those for the record. I'll yield back.
The gentleman yields back. I'm so glad that you were able to make it, Dr. Burgess. It's a pleasure to recognize the gentlewoman from Michigan, Ms. Dingle, for your 5 minutes of questions, and make sure you unmute.
Thank you, Madam Chair. I did. And thank you, Ranking Member Burgess, both of you for convening this hearing, because it's really important what is happening with COVID and the positive effects ACA has had and what is happening to people. And I too want to tell my colleagues how much I'm going to miss Susan Brooks and Joe Kennedy. They are two people who deeply care about healthcare in this country, and we'll miss them deeply. I want to touch upon a topic that we haven't really talked about as much as I think we need to be, which is the impact that COVID-19 has had on long-term care in this country and how it has exposed a number of issues in the way that we deliver it. Millions of aging and disabled people in this country rely on what is a total patchwork system of care to provide them with services and the supports that they need in their daily lives. And until you are in this system, you do not understand how broken it is. During the pandemic, we've all seen the tragic reports of how COVID-19 spreads in group settings like nursing homes. Compounding the tragedy is the fact that many people in nursing homes want to live at home with their friends and their family, but they're unable to because of the level of care that they need. And they've totally isolated, which is making it even worse as if they do become sick or what's happened to them in these last 6 months. Medicaid actually pays for things like home health aides, direct service providers to help with activities of daily living, even modifications to make the person's home more accessible. So I'd like to ask Dr. Arendine some questions. Dr. Arendine, there's been a concerted effort for over a decade to rebalance long-term services and supports in Medicaid. Can you briefly explain what that means and why it matters so much?
Sure. Rebalancing refers to a rebalancing between institutional long-term care, for instance, in a nursing home, versus home and community-based services such as home health aides or personal care provided to help a person live at home. Institutional care has always been part of Medicaid. The availability of home and community-based services has been really expanded over time, including through the Affordable Care Act. It's very important for the reasons you note that many people would prefer to receive care in their homes, would be better for their health. It's also often more cost effective for a given person to receive care at home versus in an institutional setting.
So thank you for that. I understand that not everyone who wants to receive home and health community-based services, or HCBS as we call it, are able to receive them right away. What are some of the barriers currently for people who want to receive care in the community?
One of the biggest barriers to receiving these services through Medicaid is state finances. I alluded to so-called optional services in Medicaid, which makes them sound like frills, but actually optional services are really crucial things like home and community-based services, which states are allowed to limit because they're not mandatory. And there's a really big risk that during this recession, as in the past, as states are in a big budget crunch, this is one of the places they might look to cut, which could make the problem of HCBS waiting lists worse.
Well, let me ask you two other questions. It's not funded enough even before COVID, is it? And is there an institutional bias against home-based care?
I would agree. Certainly, even before COVID, you had this challenge, and it's a place where the Medicaid program has made progress over time through continued expansions, including the ACAs, and more is needed.
So, given these barriers and the threat that COVID poses to people in group settings, it's now more important than ever that we make it easier for people to receive care in the community. I was glad to see that the HEROES Act contained a policy that I quite frankly did work on to increase federal funding for state Medicaid programs to spend on HCBC. And I've been working on with my good friend, Mr. Guthrie, and we're trying to get more of this. But Dr. Arendine, the HEROES Act would provide state Medicaid programs with a 10 percentage point increase for their HCBS programs. How would this help states to provide services to the people who need this type of care?
I think both the targeted HCBS increase in HEROES and the general FMAP increase in HEROES, the 14 percentage point bump, could be really critical in helping to fill these holes in state budgets, discouraging them from cutting Medicaid, and making it possible for them to make some investments, particularly directly responsive to the pandemic.
Madam Chair, I'm out of time, so I may ask more questions for the record, and I yield back 0 time.
The gentlewoman has completed her questions. I love the red in the background, Debbie. It really jazzes up our hearing. We need that. It's wonderful. And I like women can do it. We know that we can and we do. At this time, I'd like to recognize the gentleman from Oklahoma, Mr. Mullen, for his 5 minutes of question. You with us, Mr. Mullen? I don't hear his voice or see his face, so we'll move to the gentlewoman from New Hampshire, Ms. Custer. You have 5 minutes for your questions. Great to see you.
Great to see you, Madam Chair, and thank you so much to you and the ranking member for holding this critical hearing on the Affordable Care Act. I've said it before, I'll say it again. Across this country, 135 million people under the age of 65 have a pre-existing condition. So we know the total number is much, much higher. In New Hampshire, over 500,000 granted staters, and that's over half the population that are non-elderly live with pre-existing conditions every single day and could be denied access to health care either prior to the passage of the ACA or if the ACA is repealed by the Supreme Court. As we now know, our Republican colleagues are rushing to make happen. So even today during this pandemic, COVID-19 would be a pre-existing condition for an additional 7 million Americans. That's why I introduced the Protecting Americans with Pre-Existing Conditions Act, which has passed the House twice and still sits on Mitch McConnell's desk. And I want to particularly address my colleague, Mr. Carter, who said that Democrats are trying to create an illusion that Republicans oppose protections for pre-existing conditions. It's no illusion, Mr. Carter. You and your colleagues have voted twice against my bill, and it's very clear that you do not want to protect Americans with their pre-existing conditions, even COVID-19. Despite what this administration has claimed, this administration does not support protecting Americans with pre-existing conditions. They haven't supported it when they encourage repeal and replace without a replacement plan, or when they issued destructive guidance through the 1332 waivers, or when they fight in the courts to dismantle the entire law. And we now know that that hearing is coming just 1 week after the election in November. This is dangerous and destructive to the lives of the American people. They certainly have not supported the ACA in the midst of this global pandemic, which has needlessly taken the lives of now over 200,000 Americans. And because the stark reality is that every year of the Trump administration, the rate of Americans without health insurance has increased. This year has proven no different. So today I will focus my remarks on the ways this administration has continued to sabotage the ACA. Over 40 million Americans have filed for unemployment benefits during COVID-19. Millions of Americans and their families have lost job-based health care, and yet this administration refuses to establish a broad special enrollment period, which would allow uninsured Americans to sign up for coverage in the federal marketplace. It's especially critical in states like my own that depend on the federal government as a partner in the ACA marketplace. So Dr. Summers, most state-based marketplaces establish broader enrollment periods. Can you briefly discuss how enrollment in state-based marketplaces has compared to the federal marketplaces like our own right here in New Hampshire?
Yeah, so 12 of the 13 states that fully run their own marketplace have created COVID-specific special enrollment. And what you can see in the enrollment statistics that are available through the middle of the year is that there's been about a 15% increase over the open enrollment totals in those states. And that compares to just 11% in the states that are on the healthcare.gov platform. And note, the ranking member asked about flexibilities. More than a dozen states on the healthcare.gov platform requested that flexibility to create a new special enrollment period for COVID, and so far CMS has not granted that.
And Mr. Lee, Covered California established a special enrollment period for COVID-19. How many individuals signed up for coverage during this period?
Yeah, about 300,000. Again, I want to underscore it's both the special period because 20% would have been ineligible and they were healthy, needed coverage, but the rest were eligible but needed marketing, needed to be told to come in the door, and they doubled our enrollment from the prior period.
And based on your analysis, how many individuals could have gained coverage if the federal marketplaces experienced the same level of growth as your state did during this special enrollment period?
Yeah, our analysis is if the federal marketplaces had done what we had done, 500,000 Americans would not be uninsured today. They'd have insurance during a pandemic when you want them to have insurance to be able to get tested and get the care they need.
Madam Chair, I apologize. I've lost the clock on my screen. Should I yield back, or if I have?
Well, my clock has zeros going across.
All right. I will yield back and submit my questions. Thank you, Madam Chair, for your patience.
Thank you. Thank you for your important questions and your great work at the committee. It's a pleasure to recognize the gentleman from Montana, Mr. Gianforte, for your 5 minutes of questions. And please.
Thank you, Madam. Thank you, Madam Chair. I appreciate the witnesses being here today. I first want to say that my state has expanded Medicaid eligibility. I support a social safety net for those who need help, and I voted to protect coverage for individuals with pre-existing conditions. Today, we keep talking about coverage. Coverage does not equal access to care. Montana faces a provider shortage, and many individuals travel hours to receive the care they need. Besides protecting individuals with pre-existing conditions, my guiding principles for healthcare are improving rural access to care and reducing costs. In the CARES Act, we voted to waive several rules regarding the provision of telehealth services. We waived rules regarding the origination and requirements for physicians to be reimbursed for services provided by audio and video. I think this is a great first step, and I hope we can build on ways to improve these waivers. Director Cameron, what can you tell us about what you are seeing as far as telehealth utilization in Idaho?
Well, thank you, Congressman, and thank you for your comments, and thank you for what you did pass in the CARES Act to eliminate some of those rules, because that's been very helpful. Along with, as a state, we also eliminated rules. We really believe telehealth will provide that affordable access, particularly to rural states like yours and mine. We had a 250-fold increase. We went from up to 28,000. Where's my numbers? We went from 28,503 televisits in the month of April. From the previous year was 233. Dramatic increases in those that are accessing telehealth. And we think that will continue to grow.
Great. Do you have any indication that emergency room utilization is down with the increased use of telehealth?
Thank you, Congressman. We do have that indication. I don't have those numbers in front of me. We could certainly provide that, but we have seen dramatic increases or decreases in the emergency room utilization. But a lot of that is driven based on what was having to happen with the pandemic. Who could access the emergency room? And so it might be a little difficult to pair out whether that's caused because of telemedicine or whether it's caused because of the pandemic. And people themselves did not want to go to the emergency room where they could potentially be exposed. They could sit at their home and they could talk to their doctor and get their treatment needed.
Yeah, in my own experience talking to emergency room docs, they tell me that up to 80% of emergency room visits could have been handled through telehealth if it were generally accepted. And that's particularly helpful in states like yours and mine, where the farm or ranch house might be hours away from the emergency room. It's certainly more convenient, higher quality of care. Certainly the emergency room needs to be there for folks that need it. But having that telehealth option can provide more immediate care and also lower our costs. In a follow-up, what else could we do in Congress to help advance telehealth adoption?
That's an excellent question. I think, first of all, continue to make those rules you've set aside more permanent, and continue to encourage and allow for carriers to be able to handle those visits through the marketplace. additional support towards the technology that's needed in order for those providers to be able to offer telehealth services. I think all of those are solutions. And then really flexibility in the marketplace, allowing the marketplace to work. It will work. It can work.
Okay, so the temporary waivers we put in place in the CARES Act, you're saying we should consider making those waivers permanent? Is that correct?
Absolutely.
Okay, well, I appreciate your testimony today. And with that, Madam Chair, I yield back.
Gentleman yields back. And it's a pleasure to work with you on telehealth, which is so important and has really risen to its full benefits during the pandemic. We need to make sure that that continues. The chair is pleased to recognize the gentlewoman from Illinois, Ms. Kelly, for your 5 minutes of questions, and please unmute.
Thank you, Madam Chair. This is a very, very important hearing. And to Rep. Gianforte, I would love to work with you also. I have legislation. I work a lot with Congressman Will Hurd, but he's leaving me, so I would love to work with you on the telehealth issue. I am chair of the Congressional Black Caucus Health Brain Trust, and Black Americans make up 12.5 to 13% of the U.S. population, but we've accounted for 22.4% of COVID-19 deaths. Dr. Summers, given the number of minority individuals who gain coverage under the ACA and the decreases we've seen in the last few years, if the ACA were to be rolled back, how would that affect the already severe health disparities we are seeing because of the emergence of COVID-19?
We know that the Affordable Care Act produced particularly large coverage effects in communities of color and helped narrow, though not eliminate, the large disparities in coverage rates in the U.S. So any effort to undermine or repeal the ACA would likely worsen those disparities dramatically at a time when communities of color have been hit particularly hard by the epidemic.
Thank you. And Dr. Aaron Dine, without opening a new enrollment period for individuals and the increase in the FMAP included in the HEROES Act, how can we prevent the deaths and health disparities that we see from the lack of insurance coverage and healthcare access, frankly, that disproportionately affect communities of color?
Well, I think you would want to start with a do no harm principle. So the most important thing is to make sure that the coverage options people currently have don't go away. And then, as you alluded to, it's also important that states not be making cutbacks in coverage in this time, and that's going to require additional funding to states. But more affirmatively, there are lots of things that could be done to make progress on coverage, especially for communities of color, including improving affordability and making it easier for people to access these programs.
I know we've gone back and forth and everyone has their opinion about the ACA and who knows what's going to happen with the Supreme Court. But just to all the witnesses, if there was one thing you could suggest to improve the ACA, what would that be? I know you're not in a line, so.
I can start. I would find ways to get the 12 states that have not expanded Medicaid to do so. And these states have some of the most restrictive Medicaid policies in the country even before the law. These are very low income populations. They're disproportionately communities of color, concentrated in the South. There are large health disparities, and Medicaid expansion could be a lifesaver.
Next.
And I think the second place you would go after that is to fill sort of the next big coverage gap, which is lower income people who are eligible for the ACA's marketplace coverage but aren't enrolled, and would start by addressing affordability issues, as a number of states have done.
Okay.
And if I could, I'd build on those two with the third of addressing needs of lower income, underinsured people with employer coverage. 25% of people with employer coverage have coverage they can't afford to get access to. Those people need access to have a choice to get to a marketplace or get affordable coverage that addresses their income, which is done in marketplaces, but not by most employers.
Thank you.
Thank you. Thank you for the question. A very insightful question. I first of all, I'd work on affordability. I'd work on drawing those young and healthy people back in to the risk pool, creating one singular risk pool, regardless of the product style, adding flexibility. If you're going to have subsidies, and I think we need to have subsidies, Idaho's market is mostly a subsidy market, but we've got to figure out how to fix the cliffs and the mechanisms that keep people from taking advantage of those subsidies, or keep them from being able to access those subsidies.
Thank you.
Never go last on a panel like this. I want to echo.
You could say ditto, or
I want to echo number one and number two. In particular, half of the 30 million people who were uninsured prior to the pandemic were eligible for the ACA. That's low hanging fruit, and there's no reason not to pursue that. And then just keep an eye on the underlying competition and the value proposition in the delivery system. That remains the place that the ACA just really was not aggressive enough, and that has to be the challenge going forward.
Thank you all so much. Thanks for your patience. And to all my colleagues that are leaving the ENC subcommittee, I wish you well. I wish you the best. Thanks for all your input and insight. And of course, a special shout out to Rep. Simkus, because he's from my home state of Illinois. So thank you, and I yield back.
That's really lovely. We really are going to miss the colleagues that are leaving the Congress. There's no question about it. And as I said earlier, they're really value added, not just to our internal work, but that once those words become law, they walk into people's lives, and they're a part of that. And I think I speak for all of us when I say that I think that we've been blessed to have you on the committee. It's where we really get to know each other very well when you serve on the committee together. Now I'd like to recognize Mr. Mullen, the gentleman from Oklahoma. You have 5 minutes for your questions, and please unmute. Are you there?
Madam Chair, thank you so much. And you're right. It's bittersweet to have people leave our side. In one hand, I hate to lose them because they are a value and an asset to Congress. On the other hand, I get to move up on asking questions. So there's a side of me that's very selfish about that. But I will say, Madam Chair, you're right. When we're able to meet in person and we're able to have these hearings in the hearing room, it is something that adds a lot of value and friendship. From my friendship with Lisa to Joe Kennedy to even yourself and Diane DeGette and just a whole host of people, to everybody on our side. It is something that is tough to replace. And as you know, the stuff that I'm going through personally with my son, our committee has just been phenomenal to me. So I'll do the same. I'll miss everybody that's here, and we look forward to meeting everybody in person again. To jump into where I'm going with these questions, we've heard a lot about ACA. And I think we all agree people with pre-existing conditions need to have the access to market. I think we disagree on how to do that, obviously. And a one-size-fit-all approach doesn't work. And we've seen that in Idaho, as Mr. Cameron has pointed out in your testimony. You stated that in your collaboration and your regulatory approach that has led Idaho to have one of the most successful exchanges in the country. And it's because you went at it on your own. You designed it specifically for the people of Idaho, and that approach has been very successful. Could you kind of point out to some what regulatory actions you have taken to improve the outcomes for your patients during the pandemic?
Certainly. Thank you for the question. As I mentioned earlier, we began meeting with the carriers and talking about issues that were barriers to our consumers. Things like prescription drugs, being able to obtain their prescriptions both early, and both in larger supply, 90-day supply, and both without signing signature logs. We said to the PBMs and to the carriers that were contracting with them, you can't require a signature log, and you can't go back and audit them. We also worked with the carriers in expanding how people who were on coverage, how they could stay on coverage. And if they left coverage, how they could get back on coverage without going through all the hoops and the previous provisions. So employees that were furloughed could stay on coverage. Employees that lost coverage and went to a special enrollment period, we made it easier for them to make that transition, working with our state-based exchange, because we have that connection that was able to make it helpful. And then we made sure that people had access to coverage. We actually considered an extra special enrollment period, but in conversing with a lot of our colleagues, found that for most of our citizens, it really wouldn't address the numbers like Mr. Lee is talking about in California, and I'm glad and happy for him, but it wasn't what fit for us. And so we believe that we've taken care of our consumers. We issued about 12 different bulletins that lightened the load or the responsibility on carriers and encouraged them to give money back to consumers, help them so that they could give money to providers without it showing up as an adverse asset, or giving back to consumers without it showing up as a rebate or an illegal inducement. We had to work through all of those things.
Well, can you maybe help us on the federal level? We see a lot of states that only have one choice in the markets. How could the federal government help maybe incentivize competition in the individual markets like you have in Idaho?
Yeah, so I think that's a great question, and one that warrants a lot more deeper discussion than what I'm going to be able to give you in less than a minute. First of all, collaboration and working in the regulatory environment, discussing those rules that are keeping carriers out of the business, looking at their profitability and how, in our case, we have a co-op that we share with Montana. We have 2 non-for-profits. All of those aren't really interested in making profit, but they're not interested in losing hundreds of thousands of dollars either. So you've got to provide a balanced approach by which we're bringing young and healthy in order to help that risk pool be more stable.
Well, thank you, and we look forward to working with you more going forward. Switching gears real quick, just in closing remarks here. I heard Giaforte and Lisa both talk about telemedicine. I've got a whole new approach to it because the way my son has been having to receive healthcare lately with specialists all over the country through telemedicine, and it's something that is underutilized and something that we as the federal government should be playing a huge role in. It's something that has become very passionate, and I'd like to maybe have a deeper discussion. So Lisa, I look forward to working with you moving forward on this thing too. With that, Madam Chair, I'll yield back.
The gentleman yields back, and know, Mark Wayne, that our prayers follow your son every day, every night, all week long, all month long. We're with him and we're with you. And I couldn't mean that more.
Well, thank you. I'll tell you real quick, my son's going to be discharged from up here October 8th.
Isn't that wonderful? See?
Yeah, so we get to come back home. So we're super excited. God's just been so good to us. It's been a miracle throughout the whole process. So
well, you've given us wonderful news. And we always have to remember to go back and say prayers of thanks. We're good at asking. We have to remember to say thank you. I just want to add something, and I appreciate Mr. Cameron's work. I also think we need to highlight what California has done. Idaho has a population of 1.7 million people. The state of California is a nation state, 39.5 million Californians, and we are a highly diversified state. I don't know how diversified Idaho is, but the more homogeneous a population is relative to an insurance pool, frankly, the easier it is. So I tip my hat to Mr. Cameron for his work, but I also want to highlight what is taking place and has taken place in the largest state in the union. If the ACA can succeed in California, my contention is it can succeed anywhere. With that, it's a pleasure to recognize the gentlewoman from Delaware, a wonderful, wonderful member of our subcommittee. Lisa Blunt Rochester.
Thank you so much for the recognition, Madam Chairwoman, and for your incredible leadership on this subcommittee. And thank you to the witnesses that are here today. The passage of the Affordable Care Act ushered in a new era for healthcare and expanded coverage to more than 20 million Americans. This landmark law resulted in the highest insured rate in our nation's history. It included a comprehensive set of measures to protect Americans with pre-existing conditions. Millions of Americans have access to affordable quality health insurance because of the law. The law's tax credits make healthcare affordable for millions of Americans, but millions more are still under or uninsured. Unfortunately, Republican governors continue to refuse to expand Medicaid in some states, as was mentioned. And the Trump administration has deliberately made attempts to undermine this law. My question is for Mr. Lee, my first question. Mr. Lee, your state implemented a new program that provides enhanced subsidies for low and middle class consumers. How many individuals have benefited, and can you briefly discuss the program?
I can, and thank you very much for the question. I appreciate Chairwoman Eshu's note about California's breadth and diversity. We are a very diverse state with about 30% of our enrollees Latino, about a third Asian Americans, many African Americans. But we know the ACA is not enough. So Governor Newsom and the legislature expanded subsidies that about 600,000 or 1/3 of our enrollees benefited from, 600,000. But it included an element of having subsidies for people that are above that 400% poverty cliff. They now are, instead of spending 10, 15, 30% of their income, are getting financial help, on average $500 a month to lower their coverage. That contributed to our last open enrollment period, a 40% bump of new enrollment, healthier people, and lower costs for everybody, as well as the unsubsidized. And if I may just very briefly, we've heard a lot about healthcare costs, and we should. The healthcare costs are a problem, but recognize in the last 6 years, while premiums have doubled in much of the nation, they've risen at half that rate in California because of what we've done to implement the Affordable Care Act. So yes, let's address pharma costs, let's address consolidation, but recognize getting people insured is a benefit to everyone by a better risk mix as well.
Great. And I want to shift a little bit to the marketing and outreach that was mentioned before. And I know Covered California invested in outreach during the COVID-19 special enrollment period. I know and is increasing their marketing and outreach budget by $30 million for fiscal year 2021. What benefits has Covered California seen from their robust investments in marketing and outreach?
So I want to be really clear. If you are a Nike, if you're, I think Timberland is in your state, if you're a Ford Motor, you don't say people knew about us a few years ago, we stopped marketing. You've always got to market. But beyond that, healthcare is different. People don't want health insurance because they don't think they're going to get sick. They need to be convinced, reminded, cajoled, nudged. We spend a lot of money on marketing, but for every dollar we spend on marketing, $6 or $7 comes back to the state by lower premium costs, by enrolling healthier people. It's the right thing to do and creates a virtuous cycle by lowering healthcare costs.
And Dr. Arendine, how could investments in the ACA's marketing and outreach and in consumer assistance play a role in helping people recently uninsured because of this pandemic? Talk to me a little bit about that in the minute that we have.
I think restoring funding for outreach and marketing could play a very big role. So could opening up a special enrollment period. So could improvements in premium tax credits, similar to what was done in California. And if I could just say one word about unsubsidized marketplace premiums, because that's come up a lot. When studies have looked at this, unsubsidized marketplace premiums are ballpark in line with premiums for comparable employer coverage. But people don't see the sticker price for their employer plan. They don't see the $7,000 because their employer is paying part of it. Plus, we provide a tax subsidy for those plans. And so, of course, people are surprised by those sticker prices in the marketplace, and some find them unaffordable. You can go two directions with that. You can eliminate protections for pre-existing conditions, split the risk pool, and make things a little cheaper for the healthy at the expense of the sick. Or you can extend premium tax credits to people at higher income levels, as the bill passed by the House earlier this year would do. And I think that's the more logical solution.
Thank you so much for all of your work, and to the panelists. And now is not a time in a pandemic to get rid of the Affordable Care Act, this landmark piece of legislation. Thank you, and I yield back.
The gentlewoman yields back. We thank her for her excellent questions. And it's a honor to recognize another outstanding member of our subcommittee, the gentlewoman from the state of Washington, Ms. McMorris Rogers.
Thank you, Madam Chair. It's great to be here today, and I appreciate you holding this hearing and for all the witnesses for participating today. It's been more than 10 years now since the ACA was signed into law, and yet today Americans are still left to deal with expensive and burdensome policies. The ACA, Obamacare, was well-intentioned, but it has failed in meeting many of its goals and failed in meeting many of its promises. Obamacare promised affordable health insurance for every American and even penalized those who refused to buy it. The law has distorted markets and not controlled the underlying cost of care. Tens of millions of Americans today cannot afford health insurance, and the number of people who delay doctor's visits because they can't afford care just keeps going up. In one of 5 counties, a 40-year-old making $50,000 would have to pay more than 10% of their income for the lowest cost plan in the Obamacare marketplace. According to healthcare.gov itself, this is considered unaffordable. Unfortunately, some of my colleagues refuse to acknowledge some of the issues that continue to plague the ACA, such as higher premiums, higher taxes, and tax penalties, and even more federal regulation of health insurance. I believe that this type of government knows best approach is what is leading to more support for one-size-fits-all government takeovers of healthcare like Medicare for all. All Americans deserve a health insurance system that embraces transparency and choice, protects Americans with pre-existing conditions like my son, supports medical innovation for better care, and most of all, lowers cost across the country. To Dr. Holtz-Eakin, what changes in the way that private health insurance has covered certain services, such as telehealth visits, have you seen in your examination of the market? And what effect are those changes having on patients, the delivery of care, and the cost of care?
Well, again, telehealth has come up a number of times, and it's a really good example of a loosening of the regulations that allows a new service to be offered. That's now a competitor service to the existing delivery system. It's not going to compete on everything. It's not a great way to do an initial intake of a patient. There are a lot of other examples, but in many situations, it can provide a lower cost alternative to an in-office visit, and that's something that we want to always allow to flourish wherever possible. And we shouldn't rely on the people at CMS to sit and think, what can we provide to? We should generally have a regulatory structure that's flexible enough that if someone decides they want to do telehealth, they can start up and do it. And I'm hoping that what we will learn from the experience of this pandemic is that a lot of the restrictions on the delivery system are really unnecessary. You know, the notion that scope of practice laws are as tight as they are really restricts competition. In the pandemic, we saw doctors cross state lines of practice with zero problem whatsoever. There's a lot about this that I think is a real wake-up call to how we deliver health in the United States.
Thank you. And as a follow-up to you and to Director Cameron, obviously this pandemic is tragic, and we can't underscore the personal cost and the toll that it's had on our country. From a healthcare policy perspective, it's forced us to adapt in ways to the environment and change the way healthcare is delivered in some cases. Using telehealth in my rural district in Eastern Washington as an example, there are many ways healthcare is covered or paid for, and in the long run would improve the efficiency of this system and improve patient access. In other words, there's lessons that we can learn, and any policies that we have implemented on a temporary basis, I think we should consider for a permanent basis. And I would just like to ask both of you to highlight if what are those temporary policy changes that we should consider to make permanent.
You want to go first, Dean? So I would encourage you to take a look at the list we compiled at the American Action Forum. We have a list of all the emergency waivers that HHS has done using the health emergency declaration, and go through that list. And anything on that list is fair game to be made permanent. I think that's been, if you needed to do it to address the biggest crisis we've seen in America, and then it's something that needs to be gotten rid of permanently.
Okay. Well, thank you. Thank you very much. Always good to hear your insights. And with that, I'll yield back. Thank you, Madam Chair.
The gentlewoman yields back. It's great to see you. And now it's a real pleasure to recognize just an outstanding member of our committee. We're really lucky to have him. Always thoughtful. Mr. Welch, you have 5 minutes, and we want to hear everything that you say, so unmute.
Not unmuted.
You need to unmute. Can't hear you.
Well, I said I was.
There you are.
I was listening to you, and you embarrassed me with that introduction, and I'm not quite sure you you got that right. But I'm delighted to be here, of course, and with my colleagues on the committee. And I'm not going to rehash the ACA issues. I want to focus on some of the things we can do to address the high cost of medical care. In this country, as we know, we pay the most and get the least. And whether we have a taxpayer-funded system, an employer-based system, or individual pay system, if the cost of healthcare keeps escalating like it is, none of us are going to be able to afford it. I'm going to ask Dr. Holtz-Eakin, you make some very good comments, and I really do always enjoy your testimony. And the question I have is this: some of the information we have now is that easing regulations helps. It helps on the delivery, and it may help on the cost. You mentioned telehealth, something that I'm a very strong supporter of. But here's the question. If you ease regulations, do you maintain standards? Because, for instance, if you allow for insurance companies to sell policies that deny pre-existing conditions, then that's an option for somebody. But then when they get sick, they may well not have coverage. My view, and I want your reaction to this, is that if you're going to ease regulations, you have to have standards so that a person, whether he or she is in Texas or in Vermont, has confidence that they'll get the health care they need when they need it. Can you comment on that trade-off between regulations and standards?
So I think of this in two different areas. One of it is the insurance arena, as you mentioned. There's a difference between saying this is insurance that you're allowed to offer, having a strict regulatory structure that says what you may or may not offer, and a set of standards to say, okay, you can offer insurance. We have a minimum standard. It's not really insurance if it doesn't cover anything. So you have to have some sort of minimum standard to get federal subsidies and preferred tax treatment. And then you get into transparency and consumer protections and adequate financial backing for the insurance company itself. You can't.
Okay, let me interrupt here, because that's a very good point. But all of those things you made, that you just mentioned, do require some kind of governmental action, not just free market action, correct?
Yeah, free markets operate within a legal structure, and the legal structure is essential. There's no way around.
That's right. No, I appreciate that. And I want to go to Dr. Lee. I was extremely interested in the point you made that despite the escalating premiums, your increase in premiums has been half of what the national experience has been. Is that what you said?
That's absolutely right, Congressman Welch. And I think it's important to note that underlying costs are still too high in California. We have consolidation problems, but premiums have gone up half as much in the rest of the nation if the rest of the nation had implemented the Affordable Care Act like we did. Marketing, Medicaid expansion, getting everyone in the door to have a healthier risk mix.
And Dr. Aaron Dine, could you comment on steps? Well, first of all, just comment on what is the incredible pressure of high cost on any kind of sustainable healthcare system? Number one, and number two, what recommendations you'd make to bring down the costs?
Sure, I think you really put your finger on it. High costs are a system-wide issue, and they need to be addressed in large part on the provider side of the system, thinking about prices, thinking about utilization, thinking about delivery system reform. And so I just want to contrast that with the sort of implication that somehow ACA costs are especially high or the marketplace costs are out of control. We have a system-wide healthcare cost issue, and then we have some affordability gaps in the ACA structure that are pretty easily solvable and could address the concerns of unsubsidized marketplace consumers. With respect to continuing to work on costs, I think we actually have there are many ideas in common among the panel. I was also really struck in thinking about regulatory barriers and other barriers that have been relaxed during the pandemic. Many states have also relaxed access barriers in Medicaid and changed and streamlined their eligibility procedures to make sure people could get coverage during this period. And I think similar to how there are lessons on scope of practice, there's some lessons on eligibility there, practices that we could continue, take nationwide, and get eligible people covered without compromising program integrity.
Thank you. My time is up, but I want to acknowledge the testimony of Mr. Cameron and the successes he was able to talk about in Idaho. Thank you.
The gentleman has completed his questions, and it's a pleasure to welcome back to the subcommittee. She's an honorary member of our subcommittee, Ms. Chakowski of Illinois, who waves on, and we're happy to have you, and you're recognized for 5 minutes for your questions. Please unmute. Jan, we can't hear you. You need to unmute.
I should be unmuted now, I hope.
You are.
Thank you so much. I really appreciate your indulgence to let me wave on, and it's been an amazing, amazing hearing. I don't want to go over old testimony old messages, but I do want to say that on this day when there are now 201,000 people who now have died from the COVID crisis, and I just want to say that they deserve recognition and mourning. The families who have lost their loved ones, the essential workers who have died, and the nursing home residents that we've been trying to focus on, who failed to be protected. And the one bright light really has been the Affordable Care Act. No one disagrees that there aren't ways that it could be improved, but thank goodness for the Affordable Care Act and the difference that it has made, and really the terrible travesty of the sabotage that we have seen. I mean, I listened to all the complaints about the Affordable Care Act, and still there is nothing else right now that has been suggested. But Mr. Lieb, I have a very specific question that affects my state of Illinois. According to your testimony, California has done a number of things on its own, spent the past decade protecting, building on, and going beyond the ACA. But my home state of Illinois still relies on the federal the federal government exchange. We don't have our own exchange in Illinois. And so what I really wondered was, how has your state-based exchange allowed you to do better, to serve Californians, especially during this COVID crisis? And what would you recommend to other states in terms of relying just on the federal exchange and instead moving toward having its own exchange and the options that become available?
Okay, well, thank you so much for the question. And thank you also for your observation about taking a moment to mourn the losses we've seen around the entire nation. California is an independent exchange, but from day one, we said we are committed to building on and making the Affordable Care Act work. Building on. Cover California has patient-centered standard benefit designs. There's a great economic theories about more choices better, but we want consumers to choose between plans with good choices. We have robust competition. We bring health plans in, but we also hold the health plans to account to make sure they deliver quality care. It's not just about people getting an insurance card. So we look at health equity. We hold our health plans to account. We have very robust competition. 80% of our enrollees have 4 or more carriers to choose from. 99.8 multiple plans. We have competition, but it's also about marketing. It's about marketing and getting the word out, promoting it. I've got to note, we spend a lot of money on marketing. We spend $150 million in marketing and outreach in the coming year, and it lowers costs. It's not extra federal money. It's coming out of the premiums, but the premiums are lower because of that spending. But part of it is we have navigators. We have 10,000 insurance agents. We have storefronts with Covered California's name on streets across California, 500 storefronts. Behind those storefronts are not government workers. It's some of our 10,000 independent insurance agents. It's navigators we fund. And these are the investments that the federal government should be making to stand up and make sure that all Americans get coverage, or state-based marketplaces, many are doing similar things. And this is about getting everyone insured. It's what we've leaned in to do from day one.
I thank you so much. I really think that I would hope that we can get Illinois to follow your lead and to adopt many of the suggestions that you've already implemented. So thank you so much, and I yield back.
The gentlewoman yields back. I'm sure that Peter Lee would be happy to assist you, Jan, but here's a warning. Do not take him away from us. He's far too valuable. We need him. I don't think there, I thought that we were finished. It's really a pleasure to recognize a longstanding member of our committee. Really salute him for the work that he's done over so many years, his conscientiousness, his friendship, his effectiveness, his caring for his constituents in the country. I'm pleased to recognize the gentleman from New York, Mr. Engel.
Thank you, Madam Chair, and thank you for those kind words. And thank you for being such a good friend of mine all these years. You've done a terrific job as chair of this subcommittee, really making the subcommittee rise to an eminent place. We all know healthcare is just so important, and you come with a whirlwind of knowledge, and you actually feel it when people are suffering. I think you've done a fantastic job as chair of the subcommittee, and I was proud to be part of it. This may be the last time I speak, so I want to say that fight, obviously, that we've all been doing for healthcare and other things needs to go on, because there are many people that want to kill it, and we know that would be a tragedy. The ACA has helped nearly 20 million Americans get covered, including nearly 100,000 of my constituents. Many of these Americans gain coverage through the ACA's landmark Medicaid expansion. If the remaining 12 non-expansion states were to join the rest of the country, an estimated 2 million more Americans would gain coverage. And during the current COVID-19 pandemic, in which millions of Americans have lost their health coverage, this would provide many low-income and working families peace of mind. House Democrats passed the HEROES Act, which would provide $1 trillion in state and local relief to help support Medicaid expansion. Let me ask Mr. Cameron, could you describe why federal dollars for state and local relief are critical for supporting Medicaid expansion?
Well, excellent question. Certainly, Idaho is one of those that did expand Medicaid, although we took our time in doing so. And certainly the increased FMAP certainly has been very helpful. to us, and we have seen dramatic improvement in the number of folks, or dramatic number increases during the pandemic, and the number of folks who actually access Medicaid. We do see some that prefer not to, and the way the laws, the way that the ACA is drafted, it doesn't give them a choice. So we do have some consternation over that. We'd love to give consumers the opportunity to choose whether to be on Medicaid or to choose whether to be on a private sector plan, and think that there's a solution there as well.
Okay, thank you. Dr. Arone. Oh, okay, sorry. Millions of Americans have lost their job-based health insurance due to the economic crisis caused by the coronavirus pandemic, and Congress has taken steps to preserve health coverage by providing more funding to states for Medicaid coverage. Like my home state of New York, we have also opened up special enrollment periods for the Affordable Care Act's exchanges to enable individuals to purchase high-quality health coverage. And so far, 8,000 New Yorkers have used this opportunity to get coverage. So it's really something that's really important. Thank you, sir, for your good work. And I yield back the balance of those 12. I'm sorry, one more here. Dr. Rondine, what steps can states which run their own exchanges take to inform their residents about their special enrollment periods? And piggybacking with that, what else should Congress do?
I think there are a lot of lessons for Congress in things states have successfully done to expand coverage both before the pandemic and during the pandemic. I would put those in the big buckets of improving premium tax credits, improving affordability, both for the lower income people who are still most likely to be uninsured, and also for people who are not currently eligible for subsidies, but could be offered subsidies if premiums are unaffordable as a share of their income. Another big bucket is improving access. Making it easier for people to access both Medicaid and marketplace coverage. That's something New York has really been a leader on through its basic health program, where people can enroll all year and can more easily move between different types of coverage. And then, of course, making sure that the remaining states expand Medicaid. I wonder if Peter Lee would like to answer your question about the best ways to promote a special enrollment period.
If I may, very briefly, it really has to be about being all in every channel. Again, we spend $150 million. That's a lot of money, but we're a really big state. Any state should be spending, to our mind, about 1% of your premium dollars on marketing. And that means TV, radio, social media. In California, it means material in Spanish, in Korean, in Vietnamese. It's in language, but it's also on the ground. It's so important. We've learned half of our enrollment is through insurance agents and navigators. These are people in communities. Now, you cannot be a storefront and have our name emblazoned unless you agree by our rules. But the fact that we have these storefronts, in every community, we've got them on Wilshire Boulevard in LA, Mission Street in San Francisco, but we've got them on, Roscoe Boulevard in Panorama City and Q Street in every city, which means people know we're there. But it's because we support agents and navigators. So it needs to be everything from social media to on the streets, which right now means people still use the phone. But so thank you for that handoff, Aviva.
Okay, thank you very much. And thank you to all the witnesses again. And thanks to Chairwoman Eshoo. Obviously, we need to protect, not dismantle the ACA. And frankly, what the president is doing now is really a disgrace. And I just cannot believe that a government which is supposed to protect the people would do something to take away people's coverage, which they rely on. It's absolutely mind-boggling. So we need to be vigilant. We need to make sure that these things are not taken away and that the American people can get quality coverage. And I yield back the balance of my time.
The gentleman yields back. It's a pleasure to recognize the gentleman from Arizona, Mr. O'Halloran. You have 5 minutes for your questions.
Thank you very much. Good afternoon. And Ranking Member Burgess, thank you for allowing me to weigh on today's important hearing. I appreciate the subcommittee's attention to the importance of the Affordable Care Act as our nation is grappling with COVID-19 pandemic. The lifeline caps on healthcare cannot be imposed by insurers, and that young people can remain in their parents' healthcare until they are 26. These are a couple of the issues that are basically different than what we knew before affordable healthcare, along with pre-existing conditions. And for the healthcare industry, it's costly. Something that is seldom discussed is the Affordable Care Act's role in addressing healthcare disparities among racial and ethnic groups, as well as by income. Dr. Summers, as you note in your testimony, a staggering 19.6% of Native Americans lacked health insurance, according to 2018 American Community Survey public data. The COVID-19 pandemic has hit Indian country hard, with the per capita rates in the Navajo and the White Mountain Apache tribes in my district, both of which are had suffered amongst the highest in the nation at their peaks. A lack of preventative health care, lack of clean drinking water, and access to healthy food, and a high number of individuals without high quality health insurance worsened the impacts of COVID-19 in these communities. Much work still needs to be done, especially in light of COVID-19. I sponsored the legislation that would fully fund Indian Health Services facilities construction program to contract and improve the critical issues projects across Indian country. The urgent need for attention to this matter is why I am proud to serve on the Racial Disparities Working Group led by my colleague, Congresswoman Clark and Congresswoman Kelly, which provides an outlet to dive deeper into some of these issues and work to ensure access to quality health care and insurance for all. Dr. Dine, thank you for joining us and for all your work showing how important the Affordable Care Act has been for millions of Americans. My district is larger than the state of Illinois, meaning that we have a lot of particularly rural and underserved areas. We have broadband issues that I and this committee have been working on since I came to Congress and before. Clearly, more needs to be done. I'd like to hear more about the CAC, what CAC could do to be improved to ensure the community health centers, rural hospitals, and rural providers can continue to provide important care that those living in rural areas need desperately.
It's noteworthy that the ACA has improved coverage and access to care for people in rural areas, similarly to people in non-rural areas. And that's especially noteworthy given that people in rural areas disproportionately live in states that haven't expanded Medicaid. And so they've been left out of some of those potential coverage gains. I think one of the most urgent needs right now, particularly to address or at least make sure some of these rural access issues don't get worse, is to address the fiscal crisis that states are facing, which could easily become a healthcare crisis, particularly as states look to their Medicaid budgets as a place to cut, look to provider rates as a place to cut, and look to non-Medicaid health programs as a place to cut.
Thank you. Dr. Chalmers, the pandemic has had economic impacts throughout our country, but that impact has been particularly felt throughout poor and underserved areas, including many Native American communities. What specific improvements can we see Congress take up to make the Affordable Care Act work better for these underserved communities? And I wish to point out one other issue is that some of my constituents have to drive 10 hours round trip to see a specialist. Many of them do, in fact. Many of our veterans have to do that too. And this is just unacceptable in America that we all love. And please help us, give us some concepts and ideas.
I think there's been a lot of bipartisan support during the session today on the bolstered efforts for telehealth, which are critical in rural areas and especially in some of the communities you're talking about, where you have things, communities where it's hours from the nearest provider in some of the reservations in Navajo Nation, for instance. The ACA has produced substantial gains in coverage. A study we published looked at coverage for Native Americans and found that not only did Medicaid expansion lead to big increases in those with insurance, it was particularly a large increase for those living on or near reservations. And then the final comment I'll make on this topic is the representative from Montana raised a very good question of if you give people insurance, but they can't see a provider or there are shortages, does it matter? Well, when we've looked at the impact of giving people Medicaid expansion in states in counties that had significant provider shortages, we still found that coverage was better than being uninsured. People were better able to get care. So shortages matter. We need to address them. But having no coverage, you don't even have an entry into the system, whether there's shortages or not. So coverage first, and then we need to also bolster the workforce.
Thank you very much. I would just end with saying that we can have all the coverage in the world, which is extremely important, especially in Indian country, because the Affordable Care Act is so important to it. But it doesn't do as much good as it needs to in light of the needs of the size of the state of Illinois. 750,000 people, they have to travel a long way. There's not enough specialists. People are sick in those areas. And we have to find a better way to address the needs of all of our citizens, not just some of them. I think the Affordable Care Act is the way to do it, but changes do have to be made in light of the need for covering all of Americans. So thank you very much. You have something to say?
Congress, I was going to say one other thing is the chronic underfunding of the Indian Health Service is something we have to talk about in this context too. And that's direct funding to creating the infrastructure that can then provide the care that's needed. Health insurance coverage is important, but the Indian Health Service plays such a critical role too.
And we are doing that. And Madam Chair, I yield. Thank you.
The gentleman yields back, and it's always a pleasure. We want you to know to have you wave on. You're an honorary member of our subcommittee. How's that?
That's great.
Exactly. It's wonderful to recognize a colleague from California, Dr. Ruiz, for his 5 minutes of questions. Please unmute.
Thank you, Chairwoman. I want to also echo the sentiments on our colleague, Congressman O'Halloran, who's been a champion for Indian country and health equity in our nation. It's kind of stunning to me that we still have to hold these hearings on the importance of the Affordable Care Act, that the Affordable Care Act is still under attack, that it is still under the threat of repeal. Even now, during this nationwide pandemic, where families all across the country have relied on coverage through Medicaid expansion and subsidies for exchange plans, many after having lost employer insurance, this pandemic has laid bare the importance of access to affordable health care with comprehensive benefits. House Democrats tried to expand that access in the HEROES Act, which included my bill, the Cares for COVID Act. The Care for COVID Act expands access to health care by creating a special enrollment period for anyone without insurance and requires insurance plans to cover treatment for COVID with no out-of-pocket costs for their patients, so that copays or high deductibles would not be a deterrent for seeking care. As an emergency medicine physician, I know we need more access to care, not less, but you don't need to be a doctor to get that. You don't need an MD to realize that during a pandemic, we want to get more access to the proper care and precautions, not less. And yet this administration and some House, and Senate Republicans continue to try to chip away at the ACA while also attempting to completely overturn the law in court, We have been fighting this for years, even as millions more Americans have insurance because of the ACA. Even as 130 million people with pre-existing conditions across the country can no longer be denied health coverage just because they had been sick before. But the Trump administration, and if these Republican leaders get their way and the ACA gets overturned, there will be no protections for people with pre-existing conditions. Keep in mind that anyone who has had COVID will have a pre-existing condition. This means that they may have to pay much higher premiums for their coverage possibly even be denied, or that coverage might not cover anything related to their COVID illness, which I should add, we do not know the full scope of the long-term effects of COVID-19 yet. Or they will be subject to annual and lifetime caps or what insurance will pay. That's if they will be able to get insurance at all. Because without the protections of the ACA, all of those scenarios are possible, if not likely, as we all remember from pre-Affordable Care Act days. Dr. Aaron Dine, can you just expand on some of the impact on individuals with pre-existing conditions if the ACA were to be struck down by the Supreme Court?
I think you described we would really be reverting to a pre-ACA world where the individual market really didn't work for people with pre-existing conditions or other with serious health needs because they could be denied coverage, charged higher premiums, and because plans could have massive benefit gaps or caps on coverage. And if you don't mind, I could just say one word about the idea we've been hearing that there are proposals out there that would replace the ACA's pre-existing conditions protections. Looking at one of those bills, introduced by Ranking Member Walden, I have some real concerns. Not only would it not replace the Medicaid expansion in any way, which is crucial to lots of people with pre-existing conditions, and not replace premium tax credits in any way, which is crucial to making a market that protects pre-existing conditions actually work. Even if you just look at the impact on the market, the insurance market reforms, people with pre-existing conditions could still be charged more, either on the basis of their condition or certainly on the basis of gender or age. And plans could still could leave out high cost drugs, could leave out any other benefits, or just cap coverage with low annual and lifetime limits. And so you're back to the economic logic that pushes you to a race to the bottom in an insurance market without standards. And you really haven't protected people with pre-existing conditions in any way.
You know, this attempt to repeal the ACA through the courts is opposite of what health equity means, because it is precisely people with underlying illnesses, precisely with people that have chronic illnesses that are most at risk of dying from COVID-19. Repealing and chipping away from the ACA will add to the numbers of those who die and who suffer from this pandemic, which would only prolong the pandemic and its economic devastation for our nation. It is the opposite of doing good. It is doing harm. Mr. Lee, good to see you again. Can you talk about how individuals who have had COVID will be impacted by not having pre-existing coverage protections and what this might mean with any long-term health effects of COVID-19? Since we know it can cause scarring of the lungs, this could lead to longer-term health effects.
Yeah, so Dr. Ruiz, I'm not sure which is a better honorific, congressman or doctor, but first, it could have 7 million people not just being precluded from getting coverage, but potentially being charged higher premiums, imposing higher out-of-pocket costs. And if I may, and Aviva noted this, but remember, under the pre-ACA, being a woman was treated as a pre-existing condition. Women were charged more for insurance, and returning that reality, to my mind, would be virtually medieval. If I may, saying that you have a policy that could preserve pre-existing condition protections of the ACA without addressing the other elements, and is like saying we will keep this plane in the air by committing to not chopping off its wings, but not addressing the need to have an engine, the need to have flaps and rudders to steer, the need to have a landing gear to land. While an airplane needs wings to fly, it also needs other parts to keep it in the air to get passengers on the ground safely. You can't separate out pre-existing condition protections from subsidies, insurance rules. So to say you can do one thing alone is just both an economic and healthcare fallacy.
Thank you very much. I yield back.
Thank you very much for that exchange, and Mr. Lee for, I think, really an outstanding description that really speaks to this whole notion of I'm for pre-existing conditions, and that somehow that's something that can just take place like this without any other architecture relative to insurance surrounding it. I don't see any other members that are waiting to participate in the hearing. So I want to request unanimous consent to enter into the record the following documents. An April 2020 letter to CMS Administrator Seema Verma from members of the Energy and Commerce Committee on establishing a special enrollment period, letter from AFSCME Council 57, a statement from Margaret Murray, Chief Executive Officer of the Association for Community Affiliated Plans, in August 2020, GAO report entitled Private Health Coverage, Results of Covert Testing for Selected Offerings, a letter from the National Taxpayers Union, a statement from Community Catalyst, and without objection, hearing no objections, so ordered. Let me just close on this note, and it really is with all of my thanks. And that's on behalf of all of the members of the subcommittee. Dr. Summers, you spoke so clearly and with a knowledge that is so broad and deep, because you're caring for patients every single day, and you know their stories and you related them to us so beautifully. Thank you. Thank you for being willing to testify and for the quality of your testimony. To Mr. Holtz-Eakin, you are always welcome at this subcommittee. Both sides of the aisle draw a great deal from every testimony that you have offered. So thank you for doing that today. You're always thoughtful and you're direct in your answers, which we all appreciate. To Dr. Aviva Arendine, you're outstanding. You are absolutely outstanding. You've deepened and broadened our knowledge, never being menacing in terms of your responses. But with a knowledge that is dazzling, and that for those of us that think that we understand these policies really quite well, you did something today to really deepen and broaden it. And you're always welcome back at the committee. You added so much to our hearing. To Mr. Cameron, thank you for your testimony. To have an individual that represents, even though the population of Idaho is a relatively small one in comparison to my home state of California, your experience and your work to help ensure people was high value testimony, and we appreciate it. And I think you have a good sense of that because you evoked important questions from both sides of the aisle. And to Peter Lee, there simply is no one like you. There is simply no one like you. When we opened the hearing and I introduced you, I spoke of you're one of the most distinguished. You come from one of the most distinguished families in California and our country. And at the heart of their service and their care was healthcare. They're all physicians. So you are, you stand on the broadest shoulders. You have not disappointed anyone in generations of your family. You carry on that tradition, and Californians are deeply grateful to you. Our entire delegation from both sides of the aisle are grateful to you, and that grateful to you not only for your knowledge and your know-how, but that all of us can really sense and feel from a deep place what kind of commitment you have. It's called the Lee commitment, your fortitude. So bless all of you for working with us to really make our country better. We're in troubled times. It's up to us to help bring the American people through. And at the heart of that is the dignity of each human being. Each one has a spark of divinity to them. And honoring that spark of divinity is that they will have health care that they can and their families can depend on. That's the way we honor them. So thank you to all of my colleagues. Thank you to the witnesses. And with that, the Health Subcommittee of Energy and Commerce is now adjourned.